today's Health and Adult Care Scrutiny Committee. A few reminders for everybody. Firstly, this meeting is being live streamed, so please use the microphones and have them pointed at you when speaking. Please also ensure that you address everyone by their full title of councillor, no first names, please. And also, final reminder, please not to hold individual discussions while others are speaking. And I'd also specifically like to welcome Philippa Harding from the ICB. So we've got Philippa Harding, ICB Company Secretary, welcome. John Govett, Chair of NHS Cornwall and Isles of Scilly and NHS Devon ICB Cluster. Online, I've invited Councillor Nikki Chopak from Cornwall Council, who is welcome to participate and speak, as is Ali Bullman, Strategic Director for Safe and Caring Communities at Cornwall Council. And I would like to welcome everybody, councillors, officers. We've got a full agenda today, so let's start. Should we start with apologies, please?
Yeah, thank you, Chair. We've got apologies from councillors Julian, Hookway, McGough. Councillor Tilsley will be late, I understand, and councillors Hodson and Rousel are online. We also have Peter Hay online, the independent advisor.
Thank you, Fred. So, declarations of interest. Members, please declare any interest you may have in any item to be considered at this meeting prior to any discussion taking place on that item. Are there any declarations? Councillor Davis.
Yeah, in my job with PPG, I work directly with SWAST, and I also work alongside clinicians who are treating end-of-life patients, and I speak directly to end-of-life patient families. I also work with the NHS UCR teams as well.
Thank you, Councillor Davis. Councillor Ketchen.
I work in the NHS at the local hospital.
Thank you, Councillor Ketchen. Any other declarations of interest? I can't see any. Thank you. Item 4, minutes. Minutes of the meetings held on the 26th of January 2026. So we held 2 meetings on that date. We held a budget meeting and then a standard scrutiny meeting. The minutes have been previously circulated. Do any members have any comments on those minutes, or can I sign them as a true record? Thank you. Everybody's indicating that I can, so I shall do that. Thank you. Items requiring urgent attention. None raised in advance. I haven't got any to raise either today. Public participation. We've got no members of the public attending. So let's move to item number 7, matters for consideration or review. The first item that we shall be talking to today is the Devon and Cornwall and Isles of Scilly ICB clustering. So welcome, John Govett, again. Thank you very much for attending today. Really do appreciate it. And I know that you were unavailable, so thank you for coming along today. And I think if I can ask you to introduce your comments on this item, please. I think you wanted to speak first, and that would be excellent. Thank you.
Thank you, Chair, and it's great to be here. So what I've done, I've prepared probably about a 10-minute response to your 2 letters that you sent in. I hope they try to cover it off. I'll obviously follow it all up in writing to you after, Chair, any questions that come up as part of this. So I'm trying, Chair, to respond to the letters dated the 3rd and the 19th of March to you. Can I first apologise to you, Chair, and to the committee if you felt I wasn't wanting to attend today. It's actually my holiday weekend. It's my birthday weekend that I was meant to be away, so I shall be leaving, if that's okay, once I finish to get back to my family. I thought, and I had understood that you had a great conversation with Philippa last week, which was fed back to me as a positive conversation. And on behalf of myself and the ICB, we're working with 5 councils across our cluster, and I'm actually delighted to see Councillor Chopak and Ali Bullman, who is the statutory partner member for Cornwall and the Isles of Scilly, and represents both councils on our Cornwall and Isles of Scilly ICB. And maybe that's particularly pertinent when we get to some of the other things, because I hadn't realised those two colleagues from Cornwall Council were going to be here, but it's particularly pertinent. We are, in fact, working well as a cluster with 4 out of our 5 councils. We still have to find a way of working in a better relationship with Devon County Council. I thought for context...
Sorry, I didn't hear that. Sorry, could you just say that again? Sorry, I didn't hear that last sentence.
We have 5 councils that we work with across our cluster. We have 4 that we're working well with at the moment. We still have to find a way of working with Devon County Council in a stronger relationship. I thought it'd be helpful for the committee and for yourself, Chair, to have some context. I was unaware that the Health and Scrutiny Committee had not received the associated Devon ICB clustering governance model that you referred to in your letter of the 3rd of March. I had shared that with your Chief Executive on the 1st of September 2025, actually, which is nearly 6 months ago, on the basis that that's actually when the ICBs and the cluster actually came together. I, of course, incorrectly assumed that that had been shared with you, Chair, and the committee, but I will, as soon as I get back into the office tomorrow, I will, like I say, respond in writing to your letters, but I'll also send that documentation to you as to what was put in play in our constitution, agreed with NHS England and our own board from the 1st of September last year. So like I say, I wrote to the Devon County Council Chief Executive on the 1st of September last year about the governance arrangements and the model that has been agreed not just with the Cornwall and Isles of Scilly ICB board, but the Devon ICB board, and for that matter, with NHS England Regional Director, not just agreed by myself. I think it's probably fair to say that the cluster board, when it went live on the 1st of September, also went live with clustered non-exec appointments, but we still had 2 executive groups, and we're changing that. We've just gone through the executive director appointment process, and they will start to be in place from the 1st of April. But all other board governance issues for both ICBs, I'll explain a bit more about why there's 2 ICBs in a second, both of those constitutions were set in play 6 months ago. Now, your Devon County Council Chief Executive, of course, had been on the Devon ICB board as the statutory partner member up until the 1st of September and stood down after their 2-year term was up. And they would have fully known about these arrangements as the agreement for the statutory partner member who sits on my ICB board for Devon had to be agreed with the 3 Devon councils. And on the basis that the Devon County Council Chief Executive had done their 2 years, the replacement then was chosen not by me, but by the councils to actually be the Chief Executive from Torbay Council. So 2 important points I'm going to make now, and probably the second one is probably more important than the first, but let me start with this first point. It took for the 3 councils in Devon to agree the statutory ICB board representative on our ICB board and nominate them to me as the chair. And then I accepted that nomination. That happened to be Anne-Marie Bond of Torbay. And that's why they now sit on our statutory board. The most salient point is the statutory partner member role is clear in the legislation. It is not there to represent their council, but they're there to represent the cohort of councils that they represent in the ICB footprint in the ICB boardroom. That's not just something that applies to councils, that applies to all the statutory partner members that I have, and I have 8 of them at the moment across 2 ICBs. Hence your request from your letter, Chair, dated the 3rd of March, is not consistent with neither the legislation nor our NHS ICB constitution. I think it's important to put the context of what happened back in the 13th of March, I shall never forget it, last year, having been called to London, where the Prime Minister stood up in Parliament and the Secretary of State informed us that from with the planning exercise, 50% of ICB cost had to be reduced. In our cluster event, it actually requires us to take 34% out. That's 34% out of the ICB bit of our healthcare services, which is probably about 65 million at the moment out of what 3.7 billion in Devon. So I don't want anybody feeling, because I've had this elsewhere in scrutiny committees, it's not 34% of the healthcare services coming out, Chair. Okay. So we've been working to the Secretary of State arrangement for getting the cluster up and running, which is not a merger. I have written to your Chief Executive to explain, and to all Chief Executives to be fair, both in Cornwall, the Isles of Scilly and in Devon, that a cluster arrangement is one of those rare occasions when, if it was a merger, you'd normally go from 2 into 1. This is an example where 2 ICBs are going into 3, and I will explain that a bit more in a second. However, in the guidance, Regulation 23 of the Local Authority of Public Health and Wellbeing Regulation of 2013 that was amended, it's clear that where there's no boundary changes, and there are none, that we are able, as the NHS in England, to be able to press ahead and engage and inform and update rather than consult. When we get to merger, which is likely to be on the 1st of April 2027, there will be the need for us to formally engage and sit down. But at the pace that we're having to move, we are in the process of, across England, moving from 42 ICBs down to 26 and having requisite changes in our constitutions to fulfil that. We have tried from the 1st of September, which is when our cluster started, we have tried to engage all councils, and particularly in Devon where there is still an issue. And again, I'm delighted that Councillor Chopak and Ali Bullman from Cornwall and the Isles of Scilly are here, because we have an excellent and functioning Health and Wellbeing Board and Integrated Care Partnership arrangement. That's a new joint committee in Cornwall and the Isles of Scilly, and we're trying to find a way of sharing that with our Devon colleagues, and we're talking to all 3 Devon colleagues at the moment to get that in play. We're not getting much traction, to be fair. Although I have now spoken to all 3 leaders and all 3 chief executives in Devon, and we are beginning to make some progress. So let me talk about the 2 into 3. There are still 2 ICB sovereign boards. We haven't merged into 1 ICB. We happen to have them in a frame that sits in a Southwest Peninsula board. But where necessary, we will break and have broken into an ICB Devon board and an ICB Cornwall and Isles of Scilly board. So let me refer now to what the Health and Care Act 2022, as it's been mentioned a number of times in both your letters. The statutory council partner member, again, let me state, is not there for their own organisation's purposes, but there to represent the cohort of councils in the footprint of the ICB. Who is chosen in for that role is down to the 3 Devon councils to put forward. And as I've mentioned, Anne-Marie Bond was put forward for Torbay Council once the Chief Executive of Devon Council had stood down. Now, because we've got 2 ICBs, sovereign ICBs, I've got 2 sets of statutory partner members. Ali Bullman is one, for example, from Cornwall, but there is also one of Ali's colleagues, Ewan O'Neill, from the department, who is the Director of Public Health, as we feel that having public health around our boardroom table, and as we move towards neighbourhoods and the 10-year plan, is absolutely vital that we have the different skill sets and knowledge around the top table, not more of the same. So let me just put the record straight, as the point was made that we appear to have only 1 statutory partner member, or it was referred to at least 1 council, partner member from the Devon ICB board. In fact, if you look at what we've got on our ICB Devon board, I won't talk about the Cornwall and Isles of Scilly one, but it's replicated there. On the Devon ICB board, we have 1 voting statutory partner member, which is the nominated person that you have as the Chief Executive, which is Anne-Marie Bond. That is your nominee, which I was happy to support. However, we also have on the Devon ICB board, which makes the point we have more than at least 1 on our board. We actually have in our constitution the Director for Public Health. Now at the moment, that's a legacy that happens to be somebody who came from the Torbay Council. And having met with the leader of Devon County Council and your Chief Executive, I've made the point, if the 3 councils want to get together and actually agree to change the Director for Public Health away from Torbay down to Devon County Council, that will become with my blessing. But that is for you as 3 councils to work out who you wish to have as your statutory partner member and who you wish to have as your Director for Public Health. I've gone even further than that. I've actually got the attendee who is the chair of the Devon Integrated Care Board. Now that happens to be Mary Aspinall, who is a councillor on Cornwall, on Plymouth Council. Even though from the 1st of September, actually from July, but I'll use the 1st of September, the Devon ICP Integrated Care Partnership, which is in the legislation, has not been functioning. And I'll come back to that in a second. What I would like to say on top of this is that I made it clear, first through the previous chair who stood down on the 31st of August of Devon ICB, but I made it clear myself to the chief executives in Devon. And as Ali Bullman can testify, the way it works in Cornwall and Scilly, each organisation, so Devon County Council, are given the opportunity to write a formal update each month through the statutory partner member, which happens to be the chief executive for Torbay, so that you can write your concerns and issues such that every member of the board can be alerted to what Devon County Council issues are using the vehicle of that. To date, I've not received a single written update from Devon County Council to our board using that mechanism. I've also taken the opportunity to speak to the chief executives of both Torbay Council and Plymouth Council about our board constitutions and the way in which we're working, and they are content. So principally, we have 4 out of our 5 councils happy with the way in which we are planning. We still have a way to go with Devon County Council. So Chair, let me turn to your letters again and refer to the integrated care system, which you referred to quite rightly on a number of occasions, because the ICS, the integrated care system, is more than just the integrated care board. Core, we feel, to the ICS integrated care system governance is the integrated care partnership. And I do apologise, Chair, if in my wording back into my letter of the 13th of March to you was poor. I was trying to make the point where you quite correctly corrected me. Yeah, Devon County Council have been part of the ICP up until July 2025. But since the cluster's been in place, Devon County Council, and for that matter, the other 2 councils in Devon, have chosen not to keep what is in the legislation alive, which is the integrated care partnership. So I would like to draw to the committee's attention that on the 24th of September, only 3 weeks after I and the board started, we wrote to the ICP chair and to the 3 council Devon CEOs with a suggested new way of working and new terms of reference for both the Health and Wellbeing Board and the evolution of the integrated care partnership. I'd be happy to share that with you, Chair, if you want to see that. And we had no response in any way, shape or form from Devon County Council on that at the moment. What I would like to say is the way in which we've put forward those new working relationships is exactly how it's working very successfully. And I would like to hear from Ali Bullman, if that's all right with you, Chair, later on, as to whether she feels actually it's working in Cornwall and Scilly. Because if we have a model that's working between the ICB and the councils, we should actually take the best practice from wherever that is. Not only did I write on the 24th of September, I then wrote again on the 10th of December to the 3 chief executives. And to date, I've had no response from the Devon County Council chief executive on that proposed terms of reference relating to the ICP, Health and Wellbeing Board, and the integration of that. So in terms of the Health and Care Act, the ICP, the Integrated Care Partnership, is written into the Health and Care Act 2022. We must comply with the legislation and not consider at this point drafting policy thoughts because somebody's read somewhere in the NHS plan that the ICP may or may not be disbanded. We can't pick and choose which bits of legislation we wish to drop based on planning assumptions. Acts of Parliament need to be repealed before we make those material changes. And I look to you, Chair, and this committee to help support our ICB position on getting the Integrated Care Partnership across Devon up and running. In fact, I also wish to note a letter from the Devon County Council Chief Executive where they wrote to the Regional Director for NHS England, Sue Haney, objecting about the positioning that we were taking. Of course, my company secretary, Philip, and I then met with Sue Haney, and it was very clear in that instruction that she expected from an NHS England perspective that the Integrated Care Partnership, as it's part of the legislation, an act that's still there, must be resumed from our NHS perspective. The decision for the ICB board makeup was also discussed, and it's clear that the makeup of that sits with me as the ICB board chair, the ICB board, and NHS England to agree any constitutional changes. And we have no plans to make any review of that until we consider merging on the 1st of April 2027, not regarding statutory partner members or extra external members. I also wish to note that the Integrated Care Partnership is a joint committee set up in that Act of Parliament and is part of the duty to collaborate on both parties between the NHS, ICB and the wider council cohort for the same footprint as the ICB. And therefore I wish to reiterate Sue Haney as our regional director's commitment and expectation that the NHS work with each council to make sure there is an ICP across Devon up and running as soon as possible. Board papers and exec-to-exec arrangements. Now, there's been a number of conversations between your leader and chief executive and myself, and I've gone as far as trying to be as helpful, I hope it's been as helpful as this, despite the fact that we have the mechanism that is working through the statutory partner member, through Anne-Marie Bond, as I said earlier on. I've given access to both your chief executive and, for that matter, the Plymouth chief executive, not just to our public board paper, because anybody could get that, but I have given access to them to our private board papers as well, where appropriate. That is a material shift in openness and transparency and an attempt to work collegially in terms of the way in which that works between us. And in those board papers that your chief executive has access to on the 26th of February, we actually have started the dialogue with each of the councils about how effectively the executive teams that we're about to restructure on the 1st of April can be realigned to actually work across the entire integrated care system, as you mentioned, Chair, in your letter, whether that be the Joint Committee, the Health and Wellbeing Board, the ICP, or for the ICB for that matter. We are planning, like I say, to be live on the 1st of April with our executive top team, and as our expectation for restructuring rolls out, our next public board meeting will actually, after that, will be our May board meeting, and it's our intention to be able to work with each of the councils to make sure that we have clear alignment as to what executive teams are working with the ICB, are working with each of the councils. Because the ICP is Devon-wide, and yet we recognise and fully want to work with each of the health and wellbeing boards and each of the executive teams with each council that we have a need to work with. Now, I've also spoken to the interim cluster chief executive, who was appointed and only started last Monday. They have some family and holiday commitments in the first 2 or 3 weeks, which I was prepared to accept, but they effectively have started last week. I've spoken to them, and they are in agreement with me on our position as an ICB board membership. I have also spoken to them, and subject to your approval, Chair, I, as the chair of the ICB, would be more than happy to come to the Health and Scrutiny Committee with Devon County Council each time you request, with the appropriate senior board director that we've now just appointed, to be able to work with you and your Devon County Council executives to answer any scrutiny questions that you have. So let me now turn to the specific questions in your letter dated the 3rd of March. You quite rightly, Chair, mentioned the Integrated Care System, the ICS. That's wider governance arrangements more than just the ICB board governance. And I agree we have together to address the issue of joint working with Devon County Council and the ICB. Not in the interests of our organisations, but in the interest of those patients and citizens that we serve. So let me turn to your 3 key questions in your letter. The first was about duties under the Local Government Act of 2000 and the Health and Social Care Act of 2012, relating to democratic accountability and scrutiny of health services. You're absolutely right, Chair. And the reason why I'm here today, attending with my company secretary at the Health and Scrutiny and Oversight Committee, is that you rightly have the mandate to scrutinise the health services that we are and the way in which we're approaching these things. And this is the right place to do scrutiny by the council of what we are doing. You have our full and my full support in that. Your next question was the requirement under the Health and Care Act of 2022, which establishes the role of the ICB and the expectation for collaboration with local authority, strategic planning, service redesign, and systems governance. So let me refer again to your ICS letter. I 100% agree that we need a vehicle for councillors, non-exec directors of the ICS, of the ICB, and executives of both organisations to be in the same room, discussing strategic matters, agreeing to them, and hopefully those, as I described it to your leader and to your chief executive, setting the strategic tram lines for which councils and the ICB would then need to work within. Because if we can agree the high level, we have the guiding light, it's the NHS 10-year plan. If we can then agree the high level strategic direction under the Integrated Care Partnership, it sets tram lines for the way in which we work. And I think that landed well with your leader and the chief executive when I met with them and with Philippa and our, at the time, acting chief executive for the Devon ICB. I would also like to reach out to all partners to engage in, because for me, relationships are key here. It's people that do business, not organisations. We need the executive groups to work together now. Now, I appreciate that our ICB is restructuring, not of our mandate, but we're doing as fast as we can. But it's people that we need and executives that we need working together. So I would please call on this committee to endorse the fact that we need to get our executive groups as the first priority working together. However, I would like to lay one other challenge down to this committee. The Integrated Care Partnership is also the place where the wider determinants of health, I'm talking about housing, employment, education, particularly Devon-wide, need to be discussed. The NHS sees ourselves no longer as just a place of illness. We actually see ourselves actually working at neighbourhood and people level, place level, to actually work with individuals to make sure that almost whatever their health needs are, we need to be clear on the overall strategic direction, not just in your health and wellbeing plan for Devon County Council, but also the Devon-wide Integrated Care Partnership, and as we move forward, as what the strategy is for the cluster going forward. So I'd like to say that the cluster ICB have tried valiantly, I would say, to engage with Devon County Council at an ICS system level. And my plea is still out there. Can we please get the Integrated Care Partnership up and running? And I will be writing to you, Chair, and to the leader and to the Chief Executive of Devon County Council, based on NHSE's guidance and instruction that we have to get that back up and running as part of the legislation. For the ICP is the joint committee in the vehicle that drives the integrated care strategy. You may not all be aware of that, but that is an integral part of what we were asked to do. That needs to be refreshed because it is out of date, because we now have the guiding light, as I mentioned, which is the NHS 10-year plan. And we need to realign that as much as we need to realign under that guiding light from the Secretary of State, what we do by each Health and Wellbeing Board, and then what each council chooses to do and what the ICB then chooses to do. So the ICB, ICS and system governance is more than just the ICB board. And I would desperately want us to move on from where we are at the moment. And at the meeting I held with the leader and the chief executive of Devon County Council and my colleagues here, my colleague here and the acting chief executive from Devon at the time, I thought we'd reach some positive arrangement to be able to get both the ICP up and running. I thought we'd been clear on the IC board arrangements and looking to discuss, because it's a two-way process, all of this. Devon County Council can't impose on the NHS and vice versa. We need to work together on that and find a happy medium that works for everyone in the interests of those people that we serve. Your next point was about the council statutory responsibility for adult social care, which necessitates meaningful participation in decision making at a system level. So Devon County Council does have meaningful participation in our view at a system level. We need to get the ICP back up and running. That would be the first place to have meaningful participation. And what we also then need to do is to consider how we really then, because that's Devon-wide, we need to work as the NHS and ICB to work with Devon County Council on the way in which the Health and Wellbeing Board and the footprint for which Devon County Council currently has a footprint for, actually how we devise strategies for that. So I return to my point about I made earlier on. I've made two requests in writing. First on the 24th of September and the second on the 10th of December to try and engage in this process. And I would really welcome the Health and Scrutiny support to re-engage in that process. I think Devon County Council does have the opportunity to be represented and make its representation rather to the ICB board. I think you've got 6 routes. You have the statutory partner member, your member, who sits on our board. You have the Director for Public Health, who sits on that board. Again, my offer to you is if you want to change that to a Devon County Council person, just agree it with your 2 other councils, and I see no problem with making that change. And I see we actually have colleagues here who would actually probably be part of that decision making. So you've got a few final questions, because I know I've been presenting rather a long time, but I do want to answer your letter, Chair, if that's all right. In terms of the governance position, you made the point about having at least 1 local authority partner member. I hope I've made it clear that both in terms of the Cornwall and Isles of Scilly relationship and the Devon ICB relationship, we actually have 5 council members that sit on our ICB board. 3 of them are actually from Devon ICB, the statutory partner member, Director for Public Health, and the Devon ICB chair. So we have more than 1 council representative on there. So again, if you wish to make the change to that, I would welcome you speaking with the other 2 and change the department, the Director for Public Health, or even changing the chair of the ICP, assuming that you support getting that back up and running again. Your next point was about request to review the governance arrangements. So for your information, Chair, you may know this, but for the committee's information, I and my exec team met with the Devon County Council leader and chief executive on the 18th of February, where I made the commitment to them that I would review the ICB board governance arrangements of part of any merger arrangements that will take place, hopefully, from the 1st of April 2027. And if you work back from the start date of the 1st of April 2027, it probably means around September, October time, we'll need to get into a more structured way of having that structured debate about who sits on our board from the 1st of April next year. What I would add to that, though, is that we need to revisit the relationship at ICS level, Health and Wellbeing Board, ICP, Joint Committee level. The new council executives and the ICB need to be working together. And we should actually look towards the executives working together from the 1st of April, once we've actually got the ICP up and running. I'm nearly there. I think there is a really important point here about trying to understand the local footprint of the local government review as well. There are two elements of that. At the moment, it's very difficult to understand how many council representatives that we should have from the 1st of April 2027. We still don't know whether there's actually going to be 3 councils or 4 or any permutation of that. And we don't know yet the implications of a Devon mayor. My understanding at the moment, and it's speculation, that a Devon mayor would then sit on the ICB board. So again, it makes complete sense to actually unpack a lot of what have been the constitutional changes that Devon County Council would like to make once we know whether there's a Devon mayor, once we know how many councils there are, and once we can actually get our 2 executive teams working together. So my final thoughts, the way forward. Please, can we respect our differences? I've made this point to your leader and to your chief executive. I do understand your position. My board and I just don't agree with you. Our request is each of us stop taking up the time on legislation and what is in it and what isn't, and we actually start working together at an executive level to find ways of working that actually can make it work for those people that we represent. That means that rather than spending our time on that, we should be getting our exec teams, and to be fair, we've still got to pull ours together, so I'll put my hand in the air and go, please bear with me. It's not for the desire, it's just we have to get to the right point at the right time, because we have to consult with staff and do the due process for our staff as much as anything else, and we haven't been able to finish that process yet. The ICB and I remain committed, and I want to say that as many times as I can, to working with each of the councils, including Devon County Council, across all of health and social care partners for that matter, to find a strong working relationship between us for the future, to deliver what we are required to do from the Secretary of State, from the NHS 10-year plan, from what your council decides it wants to do in terms of its health and social care priorities, and what ends up in the increasingly focus on neighbourhood and place-based activity as part of the government's direction of travel. So, Chair, I hope that gives you an explanation to you and to the Health and Scrutiny Committee. I hope it answers the questions. I know it was rather longer than possibly wanted, but there was quite a long letter to me, so I thought I ought to have due care to respond to each of your points. I shall, like I say, be responding to those in writing to make sure I've captured all, because I've been giving a verbal update today. I'll, of course, follow up with any other questions that come from today's meeting. And I'd like to thank each and every one of you and Chair for giving me the time, because I know that's probably about a 10-15-minute presentation on our rationale. Philip, is there anything else you'd like to add? Thank you, Chair, for the time.
Thank you very much. Before I go to the Chief Executive, can I just clarify? So at the moment, we're talking about a cluster board, but it's technically it's not a board, as I understand it. Well, it may be a board, but it's not a technical ICB board. It's a joint committee from the 2 sovereign ICBs. Is that correct?
That's correct. The original Devon ICB that was put in place 3.5 years ago, whenever it was, there is still that. It's got a different constitution and membership to it, but that ICB continues. And in fact, just to be helpful, the NHS formula for financial routing of, in Devon's instance, the £3.7 billion and something like 1.6 billion in Cornwall, is routed through the 2 separate ICBs, not through the South West Peninsula. So everything up until merger, while we're clustered, is routed through the 2 ICB boards.
So when we look at the composition of that, it's like a delegated committee in a sense, isn't it? The cluster, we call it the cluster board, but it's a delegated committee. Where was the decision making around the composition of that delegated committee? Was that made by the respective ICBs?
I thought it better hear from my company secretary than me, actually, in that aspect. So
Yes, so both ICBs considered in I think the meetings at the end of August 2025, the same proposal with the terms of reference to the joint committee, and to make sure that it mirrored the constitutions of both ICBs. So in effect, the joint committee, the South West Peninsula Board, reflects the membership of the two ICB boards together. So it's a large group of people because it has both ICB boards represented on it.
And if I could just clarify one extra point on that, because the legislation is still in place for each ICB, that's why I have no opportunity to withdraw, even if I wanted to, the statutory partner members and the makeup of that, because at the moment they are writ large in the legislation. So that's why my Peninsula Board has got so many people on it, because large church of it is actually coming from the requirement to have so many partner members on it.
And looking at that, the joint board, although it's not technically an ICB board, there's 23 members with 2 from the local authorities. So that's the chief exec from Torbay and the director of public health from Cornwall. Is that correct?
No. So what you've got is in the constitution for Devon, you were referring to Devon ICB here.
No, I'm referring to the joint committee.
Okay, fine. So let me start with Cornwall and the Isles of Scilly. So there, Ali Bullman, who's on the screen here, is a statutory partner member for the council, and we have Ewan O'Neill, who is the director for public health that sits on the Cornwall and Isles of Scilly formal board. Those are the 2 roles that are in the constitution for the Cornwall Isles of Scilly ICB board. In Devon, we actually have the statutory partner member that's in the constitution, but also in the constitution is the director for public health. What we have in addition to that is the chair of the integrated care partnership for Devon. And the reason why we don't have one in Cornwall is that I co-chair the one in Cornwall and the Isles of Scilly. On top of that, there are other statutory partner members. There is a statutory partner member for the in both ICBs. We've chosen to go for mental health, NHS providers, and primary care and general practice as statutory partner members.
Thank you. Chief Executive.
Thank you, Chair. Take the opportunity to respond. Firstly, to say I think it's very important in this debate to say that at all different levels we're working strongly operationally in adult and children's services to drive through improvements and change. And as the chair of the ICB has said, that there is a fundamental disagreement here in terms of what the governance should look like. Just to say that this is a time of change. So when these changes were signalled in 2025, we did get into discussions about what that should look like. Time of change for local government and for NHS and the clustering. But up to that point, I've certainly got communications of commendations from 2 previous chairs with the contribution that I made to driving change as part of the ICB rep for the whole of Devon, and particularly in driving changes and improvements in children's services across the whole footprint. So just want to put that on record. So when these changes started in September 2025 and that communication about what that should look like, what we always do is we look outwards, inwards and forwards. And clearly in other parts of the country a different approach is taken to this. And I do have in front of me a clustering proposed changes taking place just last week in another part of the country where, you know, that maximalist approach to including all local authorities is being taken, so that every single local authority is represented moving forward in the changes that are expected. And that's because of the level of change and the level of saving. So this is an opportunity to see how we can become much more collaborative and inclusive in what we're doing. So in that letter in September, we did not agree with the changes that were proposed. And there have been many, many meetings with Devon, Plymouth and Torbay. And so there wasn't an agreement to move forward on the footprint that was proposed. And that has continued right through to the February meeting with myself and the leader, and meeting with the chair. But there's been 2 meetings between the leader of the council and myself and representative. So I think it's important to point that out. But what I'm going to go to is what other parts of the country are doing. And this is the direction of travel we want in terms of doing the best in partnership together. So this other proposed cluster board composition that was agreed last week in another part of England will have, in view of the significant changes in the remit, it's proposed that the cluster board compromises the following: 6 executive directors, 7 non-executive directors, 6 members, local authorities, with the intention that on the cluster board, 1 member from a local authority for each place within a cluster geography is represented. And it goes on to trust members, primary care members, and voluntary members. It says here, although this is a large forum, the chair and the chief executive deem this composition appropriate to ensure representation of key stakeholders and to guide the cluster safely through the transition period and mergers. And that is the piece that, in these initial discussions in 2025, I'm in full support of the leader who can't be here today, we have the largest footprint in these changes. We do have local government reorganisation, and we're not Cornwall Council. Cornwall Council at the moment is a unitary. So you've got that double thing going on of a larger scale merger of systems and local government reorganisation. And that's where we expressed that desire in the interim. That surely all members of each council could be represented. Surely, even if not a voting member, to attend and provide support and to listen, because having sat on the board for the last couple of years, it's very different to meeting colleagues in the morning for coffee, having conversations. I regularly met with the chair privately prior to board meetings to discuss local government perspective. I met with the chief executive, and then you go into a board meeting, and it is all about people and it is all about relationships. And also as a board member, we were also involved in lots of development days. We needed to build up the assurance in the ICB. And as a parity of esteem member, you were involved in all the development days and you could contribute that perspective. So it was very inclusive, it was very open. So we did ask that even if we couldn't be voting members, if we could represent for the Devon system, Plymouth, Torby and Devon. It wasn't like that before, but we're not in the same situation that we were in before. So this was genuinely an ask, and it's been a continued ask. And just for clarification in the letter that I'm quite happy to share that I sent to the regional advisor, I sent that letter because at the time I had no assurance with all the challenges taking place that the continued commitment that we need at the partnership board, because we're under intervention for children's services, I had no assurance that the staffing levels required to maintain the progress and the significant progress that we're making in children's was going to be in place, because I had not had that communicated to myself. The response I have had, and I've met with the regional advisor on this matter, and I've highlighted the risks of such change to that improvement journey, was that, as the chair has quite rightly said, it's the chair's decision in terms of what the constitution is, but that assurance would be provided to me in terms of those interim risks from one of the executives. But there has been change from the executive who left in this timescale, the chief executive, to then an interim chief executive to now another interim chief executive. So I have not had that assurance to date that the regional advisor communicated to provide me in terms of some of the operational matters, but everybody's working closely together. So that's just a journey of how some people are looking at this. It's my responsibility, along with the leader of the council, to ensure that the Devon voice is heard in all things that are happening, and it's genuinely been offered, because people will know from the contribution in the last 3 years, there was extensive work required post-COVID to reset the governance of the ICB in Devon, to reset the priorities, and for us all to work together on that. So
Thank you, Donna. So for clarification, Devon has a strong history working with the integrated care system, with the integrated care board, and my previous cabinet member, James McInnes, chaired the integrated care partnership. And indeed, I attended on occasion. Obviously, the announcement that you referred to did point to the fact that integrated care partnerships are going to cease to exist 26-27 after that year. And it gave the new Health and Wellbeing Board, and DPH might want to come in and make a comment about this, a reinstated role, I would argue, in similar to when we had CCGs and Health and Wellbeing Boards were the main representatives. So I suppose the other point I'd like to make is you're talking about membership of the ICB and you're pointing to the legislation and use the term pick and choose. And I think I would argue that's what you're doing. I think the legislation allows for more than one council to be a member of that board. Indeed, I worked in the Essex system where all 3 councils were a member of that ICB, and the other organisations that Donna has pointed to, and that's a matter of public record. So I feel I can talk about another South West system that has all 6 local authorities represented on that cluster. So I think, given the change in circumstances, it is permissible to do it. And it is, as you say, it's about relationships and about us agreeing. I hear what you're saying, you don't agree, but it's not because you can't say that the law doesn't allow it. Thank you.
Thank you, Chair. Just to provide some clarity really around the legislation. So I think we've talked quite a bit about the Health and Care Act 2022. That does set a minimum of 1 local authority rep. That is a floor, not a ceiling. So it's permitted to have more than 1 local authority rep there. That has to be read in conjunction with NHS England guidance, which really is very, very clear around actually looking at the local area, the priorities, not diluting a local voice. Both of those, the legislation and the guidance, are both current. They haven't been revoked or changed in any way at all. And both are deemed applicable to ICB guidance. So, so there's a real danger in purely saying that the law permits for 1 alone and that's sufficient. That is a view that's very much shared by ICB legal advisors. And I think, as we've already highlighted, current reports that have been published for our very, very near neighbours in the southwest have supported that. And the legal advice has been very much along the lines of actually it supports a bigger local authority representation as opposed to just 1, and would really highlight that we're talking about a floor, not a ceiling. There's a big difference. And just to clarify as well, I think on something I heard earlier, purely on the legal side, Cornwall and the Isles of Scilly are 1 local authority, 1 hospital trust and 1 locality. Devon has 3 upper tier authorities, 11 local authorities, 4 hospital trust and 5 localities. There's a big difference in the representation. So I just wanted to really clarify, when you're looking at unitary councils, we're talking about 1 unitary council in Devon and effectively 3 upper tiers and 11 councils in Devon. Thank you.
Thank you very much. I think before we go to the committee, I would just like to ask Mr. Gavett whether, in light of the comments that he's heard from our senior officers, whether he would consider greater representation for Devon on the ICB. Thank you.
May I respond first to the comments that have been made by our colleagues? Okay. It's disappointing that you've forgotten the Isles of Scilly Council, by the way. I think they would be quite upset as a statutory council to be forgotten about in Cornwall, the Isles of Scilly. So could I just pick you up on that, if I may? Also, I didn't actually say there was actually going to be 1 only partner member on our board. I made the point, I hope there was actually 3 that I've actually got on my board. The choice of those is actually down to, I'm sorry, please clarify. You said I'd made the point about
we're talking about local authorities. So we're saying we want all of our local authorities represented on it. We're not talking about different members representing 3 local authorities. I think there's a difference in view of what we're asking for.
And that's why I asked for the respect of the differences of opinion, to be fair, because our position on this is that we have 3 roles on our Devon ICB board that could easily be 1 for each of the councils. Just need the councils to get together and decide for each of the statutory partner member, the director for public health, and the chair of the ICP, which of the 3 councils would you like represented on that? So that position is clear. I still think we're talking too much about legislation and not about working with each other, and that for me is a disappointment. Your chief executive referred to other examples around the country. Now, we've gone from 42 ICB chairs down to boards down to 26. What's not well known across England is that not all of those 26 have had to cluster. So some of the places that didn't have to cluster are in a more mature place and able to move on. And I wouldn't be surprised in certain places where good working relationships with the councils actually allows to that next stage. So what works for other parts of the country works for them. We have to be quite clear what works for our cluster, both for Cornwall, Isles of Scilly and for Devon, needs to be appropriate to what we have. I've raised with you, it feels like when your chief executive referred to the points that were made, I recognise the points that are made and were made. But I also would like to bring you back to the point about the Regulation 23 that I've written to your chief executive about, making the point that given the Secretary of State's pace and scale of change and the decision by the chief executive of NHS England to cluster, that we are required across England to move at pace. And what I have offered, which I think has been missed again, is the offer that I have made that actually we will reconsult and look again towards the makeup of our cluster board once we merge from the 1st of April 2027. I think it's also important to recognise that if we don't get our executives working and functioning, the papers that they write, both to your council and for that matter to the Health and Wellbeing Board and for that matter to the Integrated Care Board, will reflect the degree of the relationships that are going on between our 2 organisations. My sincere request to you is that getting the executive groups functioning and working is the first priority, and allow us to take, while we have, particularly in Devon, in the NHS, we have major challenges, both in service offer and in terms of financial stability. We have that as a priority from NHS England to get back on track. I would suggest that we focus on making it work, getting the integrated care partnership up and running. And what I would like to talk about in terms of the integrated care partnership, that is still in the legislation and should still be there. And I know you have the opportunity, as we have in Cornwall and the Isles of Scilly, to actually change and do back-to-back health and wellbeing boards and a new joint committee. That opportunity is there to be innovative and working at place level, at county level. That's not being picked up by Devon County Council. And my request is that we actually find a way of making them vehicles that we've got at play now, making them work at executive and at place level, rather than spending our time arguing over which bit of legislation we would like to defend.
Just think it's quite simple. We're not in alignment here about representation. Fundamental, what I see happening elsewhere in such a significant period of change. Why would you not want Devon County Council represented at that absolute line of sight governance, the highest level of governance, which is really important, particularly as we go through local government reorganisation and the financial challenges facing the NHS locally. And that has been the offer from myself and the leader of the council. And it's one of, as I say, historically, we have worked really well together in terms of the progress that's been made. And it's I think, not to have the Devon voice represented, when I see other authorities during this period of change having the opportunity to represent their communities, and it is all about people and relationships, being in and around the board, being over in joint buildings, working together. Extensive work has taken place, and my concern is that the changes that are being sought don't build on actually what we had in place, and don't provide that opportunity, because fundamentally writing a paper and submitting it to a board is not the same as having the opportunity to come forward like today and be able to speak to that information at board level. So I do think it's a democratic deficit, or an officer deficit model that's being proposed. Chair.
Thank you. Tanja Foster, and then I think Mr. Govett. Thank you.
I'd just like to come back on one point. So it's BSW and they are clustering. I think the difference is I don't think you're talking about representing the views, but I think you're not really representing the views of the whole system, because we're in a key partner in this system. It should be a level playing field. A local authority is equal to an NHS representative, and I don't think we feel we're being listened to. And I think what this is evident of is that they got into a room and they agreed it for the same reasons that we're asking it, because you've got 6 local authority areas coming together, which is why all 6 are represented. I was there in Essex when we put together the ICB. Lots of difficult, challenging discussions. I worked for Southend at the time. Southend were committed that they could only represent them. They wanted to be part of that board, and the then chair agreed that all 3 upper tier local authorities could be part of it. So I agree with you. It is about relationships, and I think it's sad that we're having to have this conversation at Health and Adult Scrutiny, because it doesn't create the right environment to have that conversation. But I think we're just frustrated because we are trying to work with you and trying to say what it is we think is needed, particularly at a time of significant change. And you referred to LGR. You've got a significant reduction in costs that you're going to have to make. That's going to be really challenging for the people of Devon. We are going to have to work together to change services that still enable people to get the outcomes that they need, and in an equitable way. And how can we do that if we can't agree something as simple as a clustering committee? Other areas have done it. So I just wanted to raise the point that it is a clustering area, and that they have managed to come to this agreement.
Okay, thank you. I would like, if I may, to try and get a formal response, which is binary, a yes or no. Is the Chief Executive of Devon County Council going to work from this afternoon to get the Integrated Care Partnership back up and running? That is the highest level of integrated care system governance. Despite you think, I'd love to think the ICB was the most important one in the journey, but it isn't. If you look at what came out of the guidance when the ICBs were first set up. So I'd like a binary understanding from that, please. I'd like to understand why Devon County Council doesn't feel that my offer of having the Director of Public Health actually changed from being the Torbay lead to being the Devon County Council lead, doesn't actually then have Devon County Council representation around our boardroom table. If what the Chief Executive is requiring is that they have to sit around the table, I would ask the question, are you suggesting that the Chief Executive of Torbay is not representing Devon County Council? And if that's the case, I sincerely ask you to pick up the phone and have a discussion with your statutory partner member as to why it's not working for you.
I think Devon's just looking to be represented on the ICB
I've given you the offer, Devon.
in its own right, not taking the seat from somebody else.
Okay, well, I've given you my position on it, Chair.
Let's move to committee. Thank you very much. Thank you. Councillor Morgan.
I do find it incredible that a county with nearly 1 million people has no direct representation on a board such as this that's so important. And I also want to comment, this is why the public despair with us. It's become a bureaucratic bog that is going to impact them. And you know, for goodness sake, we've sat here for over an hour now talking about who's going to be on what committee, and who's going to be the grown-up in the room and say, yes, okay, yeah, that can happen. Because we need to do that for the sake of the, you know, nearly 1 million people that live here, and plus the huge amount of significant number of people that come every summer that are also going to be impacted by this. It's not just the people of Devon, it's the people that visit Devon every year when our population just grows hugely. So please, for goodness sake, we do need representation on that board, because there's just too many people, too many people's interests at stake here. You know, not just the county council, not just boards, not just bureaucrats who are on boards. It's the public. It's the public that are going to be impacted by this, and they need to have a voice on that board.
Thank you. Councillor Ketchen.
This feels like an alarming place to witness two groups of professionals who know their work and know their remit, unable to agree. Whether or not Devon is, or how Devon is represented is not the point I want to make. Everyone's saying that this is about building relationships. I see a relationship breakdown, and I don't know where it's begun. And I think that the people that we're talking to here need to find a way to renew the relationship, work on that, transform the mood music, and go away, not in front of us, but between themselves, and rebuild the relationship. And how that's done really isn't the business of the committee. I feel it's between some excellent professionals that I can see gathered today who want to do the right thing for their services.
Councillor Dawson.
Thank you. I was just making more notes, actually. I guess I'm a bit confused, because we hear quite often from ICB, from any sort of NHS projects, that this is about place and people and delivering services that are built from the community up. And yet all I'm hearing today is that a decision has been made to have a more closed approach geographically to other places in England. If I'm hearing about places that have where actually, if Devon was elsewhere in England, we would have a place at that table. I'm a bit confused as to where, you know, partnership working is really, really important in health, and we hear that a lot. Sorry, I've got a sore throat today. So I'm a bit confused as to why any stakeholder, significant stakeholder, so in this case Devon County Council, wouldn't, where putting together this new ICB board would not automatically mean that every single significant stakeholder who wants to be at that table and has something to bring in representing nearly 1 million people, why that would not be automatically part of that design. I'm really struggling with that, because it seems so incongruent with everything else that we hear with the ICB and with the health service. So that's confusing me. So I'd like some clarity on that, because I think the opportunity here, or the opportunity was to create something that included everybody and made sure that all areas were represented, and that seems to have been missed, and maybe I've missed a vital point on that. I appreciate that there could be the opportunity for Director of Public Health for Devon County Council to take the place of the current Torbay representative, and that's great. I just don't think it's enough. I don't think that shows equity with authorities, and I don't think that's a particularly positive step for the relationship as a whole. And I'd agree with other councillors that this needs to be sorted out and get everybody around that table to make sure everybody's represented, everybody's on equal footing, and that every resident's interest across the whole region are put forward and heard. So I guess if the very least in the very short term is about the Director of Public Health for Devon County Council to take that place, I wonder if you could confirm here now what the next steps would be and how quickly that would happen, because I think there's been a long period of time where Devon haven't been at that table. Thank you.
Councillor Tilsley.
Thank you, Chair. I think it's wonderful that you're such a vocal proponent of the Isles of Scilly. That's fantastic. The Isles of Scilly has approximately the same population as my local parish. Torbay has over 100 times the population of the Isles of Scilly, and it's wonderful that their Director of Public Health is on the board. Devon has 300 times the population of the Isles of Scilly. I think it's odd that we'd have to choose whether we have the Director of Public Health for Torbay or Devon sitting on this board, and I realise the Isles of Scilly don't have their Director of Public Health, but they come up in these conversations an awful lot more than the people of Devon. The democratic deficit, as the chief executive points out, feels strong, and I think an either-or decision about those members seems unjust. Short and sweet from me.
Committee members. Any further questions or comments? Councillor Rogers.
How do we get a way forward outside this room? Because clearly there's a difference between Devon and the Integrated Care Board. How do we get a solution out of this room? Because we're not going to solve it, I feel, today. We've got to remember people are dialing into this from the public, and what will they think? And what is a way forward? Because I sense we're not going to solve it today, but we need a way forward.
I think what I would like to say is that I really support rebuilding and having a reset. I fully support that, but I'm really struggling to see why Devon County can't have its own seat on the ICB. I can't get over that hurdle, and we've heard from other ICBs and the clustering. So there's two stages, aren't there? There's the interim stage, which we're in at the moment, which is where we're clustering and the two ICBs stay as sovereign bodies. And then we've got the post-transition phase, which is expected to be April next year. And that's great that there will be a formal consultation on the new constitution. But we're in a huge change, a transition phase. And I can't understand why, if the legislation doesn't prohibit representation from Devon County Council on the ICB, we've heard that other clustering has representations from every local authority. I'm really struggling to see why we can't have that, and I can't overcome. So I'm all for kind of further exploring around the ICP, for working together, for meeting informally, to try and kind of build relationships. But I can't personally overcome the difficulty that I have that we represent around 800,000 people, and it seems to me a reasonable ask for Devon County Council to have a seat on that ICB, and I don't know whether my colleagues feel the same way. And I'm looking around the room, and so as part of a recommendation, I would be looking to urge the reconsidering of the current board, well, I say board, I mean the delegated committee, to include full representation for Devon County Council in its own right, because that to me seems to be a reason, not unreasonable, quite reasonable, very reasonable. So I don't know whether the committee wants to comment on what my thoughts are. Councillor Morgan.
I agree with you wholeheartedly.
Vice Chair.
Thank you. The ICP is to cease to exist in not very long. It seems odd to put so much time and effort into building up a body or rebuilding a body, I think it was put earlier, to something that will then cease to exist. It could be in a few years, but why not build up that relationship and that working relationship on the body that will continue to exist?
Councillor Jones.
I'd just like to say I would like to support the point of view that you have summarised, which I think represents the views of the committee.
Councillor Dawson.
Thank you, Chair. Yeah, I'd support you in that proposal, but I would also like some clarification as to why, when the opportunity has arisen to redesign things and there is precedent for a more inclusive board, why that hasn't been taken. So I would like us as members to get that clarity as soon as possible, please, because it just doesn't feel like a sensible decision. Thank you.
Thank you. So I think it doesn't have to be a kind of either or, either a seat on the ICB or reinvigorating the ICP. I think it could be both. Am I right in understanding that, Maria?
That's correct, yes. Legislation doesn't prohibit additional, so it's not an either or.
Steve?
Thank you, Chair. Just a couple of points from me, if I can. Just for the committee's kind of history, really, I suppose. So just winding back to when the ICBs commenced, we had a decision made amongst the three directors of public health, so Torbay, Plymouth and Devon, that one of us would represent the three of us. And that would not be the same local authority as a chief executive. So in essence, you had two bases covered rather than three. So I took up the mantle for the first couple of years representing public health on the ICB. At the time, chief exec for Plymouth, Tracy Lees was the chief exec, and obviously with and also Lincoln Sargent was the public health representative on the integrated care partnership. So we had that kind of agreement. Obviously, Chief Exec Donna standing down and Ray stepping up. We haven't revisited that. I handed the baton over to Lincoln while Donna was still Chief Executive as well, primarily because Plymouth's situation didn't lend itself to their Director of Public Health. So in answer to one of the questions around can the Director of Public Health and myself talk to Lincoln and suggest that that's certainly a possibility. I would argue I don't think it necessarily solves the issue we're trying to solve here today. And just the other comment just around the Integrated Care Partnership and Health and Wellbeing Boards. So we have three separate Health and Wellbeing Boards at the moment. They are statutory subcommittees of the local authority in statute 2012 Health and Social Care Act. We can't merge those boards. They are three sovereign boards. I would say though, over the last 3 or 4 years, we have had quite productive conversations with elected members of the chair of the boards and the lead officers for the three local authorities. And when you look at our health and wellbeing strategies, not unsurprisingly, probably the 80-20 rule works. So about 80% of the strategies are very familiar in terms of the priorities you're focusing on. But one would expect about 20% is different because Plymouth is different to North Devon and Torbay, for example. So we can have those conversations. We do have those conversations in the past. We've had quite productive conversations and come together on more than one occasion. But those three health and wellbeing boards, as far as I can see in legislation and the health and the 10-year plan, are being strengthened, and they will be based around the upper tier authorities as they currently exist, notwithstanding what's going to happen in the next couple of years. So just a couple of points just in terms of organisational memory around why Lincoln is the Director of Public Health for Torbay, sat on that board. It was originally me, and I handed the baton over to Lincoln and the health and wellbeing board. It's just helpful to clarify that. Thank you.
Thank you. Steve. So also members, I've reached out to Cornwall because Cornwall Council, so we've got Councillor Nikki Chopak online, because going forward, so we're in the transition phase at the moment, but obviously there will be a formal merger of the ICBs expected to be in April 2027. So I think there will be strategic issues that cross the entire peninsula where it will be helpful to have a kind of oversight and to work together with Cornwall. That's certainly not to get rid of our individual scrutiny committees, but I think there will be overlapping issues going forward. So I hope that we can work together, and if it's okay with you as a committee, I will discuss with Councillor Chopak the ways in which we can do that going forward, so that we can bring back maybe at the next scrutiny committee what that could look like. There's a whole range of very informal approaches where we could look at working with our different work programmes to forming the other end of the spectrum would be to have like a formal joint committee that would look at specific strategic ICB issues from a scrutiny perspective, and also to discuss that with the other unitary councils. So if it's okay with you as a council, as a committee, then I will look to do that with Councillor Chopak after this meeting, going forward with bringing together some ideas for the committee to look at. But I think what I'm hearing from the committee is support for the idea that we urge the parties to reset the relationship between Devon County Council and the ICB. We urge the ICB, and I think that will be the chair and the newly appointed interim chief exec, to appoint a representative for Devon County Council on the ICB, the joint committee. I think that's, what's that, sorry? And to reinvigorate, and that's right, thank you, to work to reinvigorate from Devon County Council's perspective as much as we can the ICP, the Integrated Care Partnership. So I don't know whether that sounds acceptable to the committee, whether you, oh, and sorry, Councillor Dawson's point as well.
Yeah, thank you. And my point was just about clarifying why that decision has been made, so we can understand that in resetting that relationship.
Yes, so we can include that as well. So do members, oh, Chief Exec.
Yeah, I think it's important to say this is a dispute about governance. I know people have used the word relationships and it's a time of change, but I started off by saying today that you know, because the executive relationships are in place at every level. We've evidence just last week in looking at our SEND progress and one of the joint boards with government, the DFE, there was exceptional progress reported there in terms of what we're doing in children's and clearly in some of the transformation programmes in adults. So I think it's important to say that the professional relationships focused on improving outcomes for services and residents of Devon, that is not the issue here. It's a dispute about governance is what we've got. So I think it's really important to state that. I met with the outgoing interim chief executive just last week and continue to do that. New interim chief executive just coming in. So I think it's important to state that has continued throughout and we can evidence really good for the residents of Devon listening today that the improvement and transformation programmes we have in Live Well, the improvement and transformation programmes we have in SEND and Children's Services are all making really good progress. It's just the fact that we have been looking outwards to see how in this period of change there is an opportunity to have different structures and governance and look at best practice in that, and that is what as officers we're seeking here, and that's the point. It's not about things being broken. I think it's really important for the public to hear that, but it is a dispute about the changes in the governance, and we're quite happy to circulate to the committee what people are doing elsewhere. Thank you.
Thank you very much. And just before we go to a vote on that, can we hear please from the committee specialist advisor to comment? We have Peter Hay online. Hi, Peter.
Hello there. Sorry, trying to get two fingers to work on two clicks. I think what I've said very clearly earlier on is to use the expression used by the Health Devolution Commission about parity of esteem. And I think that's absolutely vital here. This has been a hard watch. Some of that feeling of a lack of parity esteem predates John and the ICB, and it comes from the decision to move to 24 arrangements for ICBs as against 153 and growing number of councils. And I think that also comes at a time when councils are really integral to particularly the left shifts to a preventative, community-focused health service. So I think how to find the right engagement with local authorities to tackle issues which are much more than about one piece of health or care, they're about how everything interfaces, is really critical. Both sides are right. Legally, it does come down to what John says is about opinion, and it's very clear, I think, in the room what the opinion of members in relation to Devon County Council is, and I think that needs some reflection. What I would say, I think, really powerfully is that integration is an extremely gentle being, fragile being, and it requires handling with care. So I think actually this is a really vital moment to think about how that happens. And I think what you've proposed, Chair, is about what the role of this committee is in keeping an eye on those arrangements. And indeed, I think alongside that, how that's being carried out at an executive level, as Donna has just put together, whilst there is some resolution found to how the strategic representation is carried out, if that makes sense. So I think it's important to keep an eye on the range of mechanisms that are being proposed and how that then plays out in the executive arrangements and add those to your kind of oversight. Hope that's helpful.
Thank you very much, Peter. So if we could go to a vote, please, on what I've proposed. So I'll propose that.
Happy to second that, Chair.
Thank you. Thank you very much. Should we have a 5-minute break?
So that is 2014.
Welcome back, everybody. So if we could restart the meeting, and we're on item number 8, which is the housing update. We've had a written report, and I think we have Tandra Foster, Sove Wright, and Amy Howard, and Councillor Keeling. Councillor Keeling, would you like to comment? And we also have Giles Colton online. Thank you.
Thank you
Councillor
very
Keeling.
much, Chair. Thank you. I'm glad you remembered I was here.
How could I forget?
So thank you, Chair, colleagues. The report explains how housing responsibilities work with Devon's two-tier system and how these arrangements support adult social care. District councils hold statutory housing duties, including planning, homelessness, housing allocations and standards, while Devon County Council plays a crucial strategic role. The county provides population and needs data, shapes the specialist housing market, and works to ensure that the right type of homes are available to promote independence and reduce reliance on formal care. Strong partnership working is highlighted with regular forums between county and district councils. Positive collaboration has influenced local plans, supported developments of extra care housing, and improved provisions for people with disabilities and autism. The report also covers new statutory guidance under the Supported Housing Regulatory Oversight Act of 2023, which requires district councils to produce local supported housing strategies by 2027. Although districts hold the legal duty, county councils have key strategic and commissioning responsibilities, and joint work across Devon is underway. The Devon and Torbay Combined County Authority, the CCA, also plays an emerging role in strategic housing planning. Housing is a priority in the CCA's local housing plan, emphasising the integration of housing with healthcare, transport, skills and employment. The main focus is the need for specialist housing, supported by ongoing work with the Housing LIN to produce a specialist housing needs assessment. If I can mention, Devon has only 305 flats currently in our 6 extra care housing schemes, with 3 more in development and a further scheme identified in local plans, an additional one being scoped at Teambridge in Bradley Lane, a brownfield site in Newton Abbot. This scheme supports independence by offering on-site care, flexible support and community-based living, something I wish to promote at every occasion, as you're aware. Chair, we are happy to answer any questions that you may have.
Thank you very much, Councillor Keeling.
So I think Councillor Keeling has summed it up really well. I would just say we've got an ageing demographic in Devon, and we also have a significant working age population, so more babies surviving birth with significant disabilities, learning disabilities. Housing is one of the options for us to help people live independently and better lives, and also with greater value for money. So this report is hugely important in that context. I think the housing needs assessments that have been completed in partnership with our district councils will really help sort of get the best for Devon's residents for the future. So I just wanted to make that point. We've actually got Giles Colton here, who has done tremendous work for us on our behalf getting this off the ground with others, and I think he would be able to answer any specific questions that people might have. Thank you.
Thank you. Members, who would like to ask any questions, make any comments? Councillor Rogers.
Thank you, Chair. Within my division, half my division is in Dartmoor National Park and half isn't. I want to pay respect to Councillor Buscombe, who is the portfolio holder for Teambridge, because collaboratively we are working with Dartmoor National Park to work out what we need to do more of to get more provision for that initiative within Dartmoor National Park, which covers South Hams and West Devon as well. And if you've got any practice you can share, do you work with the national parks, who are the housing, the planning authority and the housing authority in national parks for allocation?
Giles.
Sorry. Can you hear me?
Yes, thank you.
Oh, sorry, I didn't know if the connection was working. Yes, we do. We've had some conversations around the housing LIM work and continue to work with them and all interested parties really in that regard.
Thank you. Can I ask a question, please? So we're preparing a housing needs assessment, and that's part of the work for to enable our district council colleagues, and I'm a district councillor at East Devon, to create their strategies. But my question is, from a Devon County Council perspective, what's the baseline of unmet need? So in the report, I can't see, so we're obviously doing an up-to-date assessment, but what do we know about how many people are looking for particular types of accommodation, where the shortfalls are, what the age demographics are, where which districts that unmet need falls within? Have we got a baseline, or are we starting from scratch, or have we got a pool of information already?
So did you want me to answer? Yeah, so all of that work is Councillor, is part of the needs assessment work. So we baseline services, we've looked at demand for different types of services, we've looked at our strategies, looked at our where we see increasing need coming through for different cohorts of people and for different age groups as well. And all of that will forms part of what will be in the first published needs assessments, which we hope to do in the next few weeks. We then, the plan then is to take that work into the further work that the Supported Housing Regulatory Oversight Act requires of districts, and we're talking with lead housing officers about that, such that we can further develop that, add strategic aims around that, and ultimately a delivery plan as well, which is part of that same work, and that's the work which the SHROA requires over the next year to be delivered by March 27. So we're essentially in a better place than we might have been, because we have that needs assessment on the cusp of being delivered.
Thank you, Giles. So when, for instance, there are 6 schemes that have been delivered at regular intervals, and they're in the report at 3.65, there, I think 6 extra care housing schemes. How did we know that was the right kind of housing in the right kind of place?
So some of it will have been, so in terms of the delivery of those schemes, they've come through over the last sort of probably decade in terms of delivery. They've some of which have been opportunities which have come up through land becoming available. We've not taken any site, we take sites which are where there is demand. In terms of the needs assessment work going forward, we've specifically looked at the baseline of older people principally, but we've also stretched that into younger adults as well. We've looked at our strategy around wanting to divert people from care homes and residential care homes, and all of that work comes together to make a forward-looking prediction around the requirement for extra care over the coming, I think it's 20 years in total. We've done that at 5-year intervals. And we've also broken that down to district level as well. So all of the report, all of the sections, so there'll be sections on different cohorts, they're all broken down to district council boundaries, because at the time we commissioned, we felt that was the best way which was last year, to deliver that work.
And sorry, just one further question I've got. So in 3.7.2, it's looking at understanding the future demand for specialists in supported housing, but all the different categories seem to refer to older people. And I'm just wondering about the working age adults, and whether that's a key part of the needs assessment work that's being undertaken.
Yeah, so the work covers specialist and supported housing in its full gambit. So it does go all the way from older people through younger working age adults who might have a learning disability or a physical disability, all the way through to teenage parents actually as well, and other groups in between. Chair.
Thank you. Committee, any questions? Councillor Dawson, then Councillor Tilsley.
Thank you, Chair. I just wondered if part of that work around the housing needs assessment, will they also be looking at historical needs as well, so that we can start looking at how needs are changing in Devon? We know that lots of people move to Devon. We know we have an ageing population, and we have all the other statistics that have been put for us. So are they also looking at that so that we can start predicting what issues and what gaps there might be in the future, which I guess politically will help people to lobby government, for example. We talk about fair funding for Devon a lot. If we can, it's probably part of the work, but that prediction I think is key for not only resolving issues now, but also looking at what we're left with in the future. Thank you.
Yeah, so we've certainly taken some of that into account, and have a further opportunity to do that, I would suggest, as we work through the Schroer work over the coming year as well.
Thank you, Councillor Tilsley.
Thank you, Chair. Building on the Chair's final question as well about workforce and working age people, is there anything in the strategy about where we want our workforce to be? Every part of the service, the integrated adult social care and health service that we've looked at recently has got issues with workforce, not having enough working age people in the area, especially North Devon. Is there anything in the strategy about making sure that we're making affordable houses where we want people to go and work for us?
Yeah, it's a good challenge. So the supported housing regulatory oversight work that we've described doesn't its main tenant is not focused on that, but the partnership that we built around that is an excellent opportunity, I think, to take forward exactly the challenges that you raise.
Thank you, Councillor Rogers.
Thank you, Chair. Within existing successional tenancy holders, some successional tenancy holders have single people living in 3-bedroom homes. They do not want to move out of where that location is because they have family and supportive ties. Do we have any data as to how many people are single living in larger dwellings in Devon, and what we can do to get a plan together, try and get them to downsize, help them declutter, dehoard? Do you have any of that data? My other question is, do we have any data that says what the writer's rent bill as county level is having an impact on in no fault evictions before it becomes statute later this in May?
On your first point, I don't have any specific data, but we could certainly take that away. The concept of move on, which is principally what you're getting at, freeing up larger houses for families, is absolutely part of the Schroer work that's described within the statutory guidance. To your second point, again, I would have to take that away. I don't have any specific data in that case, I'm afraid, but we could certainly look at that.
Councillors, any further comments, questions? I think what I would like to be clear on, and maybe just change those recommendations slightly, is that to be clear, when the housing needs assessment, I understand that it's imminent, but I would like to be clear and set out in our recommendation a specific date when that specialist housing needs assessment is going to be delivered by. And also what I'd like to be clear on is that we're creating or working with the Housing Lend to create the housing needs assessment. But then how do we deal with that going forward? Because obviously the County Council doesn't hold statutory responsibility for housing, but somehow through that needs assessment and then through the District Council's strategy, we have to continue to work with our District Council colleagues so that we have oversight on the kind of housing that's being delivered, the unmet need. So I'd like to kind of build that into a recommendation. So we're not just saying come back with the housing needs assessment, but that we're clear that this committee has a key role in kind of moving forward, and obviously we've got LGR, but we don't, that's next year. So we need to be clear that how we work with our District Council colleagues to have oversight, because it has a direct impact on the county, doesn't it, and our adult services. Tandra.
So I think we could absolutely do the timelines. I suppose it's a question to Giles, really. Think about the governance. This has to be agreed in partnership. And I think that's usually done through Team Devon, but Giles will correct me if I've got that wrong. So I think in terms of the recommendation, we need something built in, because I think that's the group that Scrutiny need to influence, if you like, into. So we've got track record. We've got housing developments. You can see where they've put things in the local development plan. But what you would anticipate is the outputs from the needs assessment would start to feature in the local development plans going forward. Irrespective of LGR, the people are where the people are, aren't they? So.
So, yeah, so sorry, Giles, do we know exactly when we're going to have the assessment by, please?
You're going to ask me to give you a date, aren't you? So we are in the process of about half the chapters are finalised, and about half of them still need still getting some final data. If I said May, that would probably be safe. We hope to do it earlier than that.
Thank you. So if we slightly change the recommendation, so it says something like, note the current work with Housing Lend and development of a specialist housing needs assessment due before the end of May 2025.
Yes, that's fine.
And then hold a masterclass shortly after that time. And then request oversight of that going forward through the council's, the committee's work programme. Does that sound acceptable? Any comments? Councillor Dawson.
Only just can we clarify about the sort of prediction of future needs, because I think that's really important, particularly if we're working with the district councils that are delivering. Does that need to be written into this, that there will be a spin-off piece of work, or is it just a given that that will happen and come back to this committee? Or thank you.
What do you think?
Sorry, Chair, you could request, as you've set out, request oversight of this piece of work, building it into the scrutiny work programme thereafter, and you can include in there that explicit around the housing needs of the workforce, words to that effect, if that's helpful.
And the future predictions.
Yeah, the future predictions of the workforce.
Thank you. Any further comments, or should we go to the vote? Does that sound acceptable? Okay. Proposer?
Happy to propose, Chair.
I'll second that. And should we go to a vote? Does that sound okay to everybody? Thank you. Thank you, councillors. Right, moving on. Next item is the deprivation of liberty safeguards. And so we have our report. We have representatives from Integrated Adult Social Care. So I believe that we have Sandra Geary. Welcome, Sandra. Kevin Beveridge. Welcome, Kevin. Tandra Foster. Sophie Wright and Amy Howard. So we have your report, but I think you would like to speak to your report. Kevin?
Yes, thank you, Chair. We have a short presentation for committee. First of all, I'd like to say a big thank you to Sandra and the work of the team for driving the improvements that have been made possible by the additional funding that we will speak to in this presentation. So next slide, please. Just by way of context, deprivation of liberties effectively covers two parts. It covers those settings such as care homes and NHS settings, hospitals, where people might be deprived of the liberty because of a lack of capacity. And the role of the team is to make sure that those deprivations are necessary, they're proportionate and in their best interests, and that safeguards around their ability to challenge, appeal and get representation for those deprivations are put in place. The other side of that are the individuals who might live in community settings in their own home, as we heard from the previous presentation, supported living settings, where those are authorised via a court of protection rather than through a dole's route. And those are the main areas of work that the funding and the improvement plan is allowing the team to develop. Next slide, please. Again, by way of context, in 24-25 financial year, Council agreed additional funding of £500,000 to ensure that the focus of the team was very much around risk assessing, appraising the risk of the individuals who were waiting for dole's work, and that obviously set the direction of travel, allowed the team to develop the improvement plan and to plan for the future investment. So in 25-26, the council invested £1.5 million that allowed the team to begin to develop its workforce plan, begin the process of recruiting. There are challenges around that recruitment, and I'm sure Sandra will say more about those particular challenges in a moment. At its heart, this investment is very much about the individuals. So it is about ensuring that, yes, we have good processes. Yes, we address in a timely way those referrals for adults. And it is obviously about reducing waiting lists, but it is also at its heart, it has a strong improvement focus, improving practice and process. And by 27-28, we will have a permanent increase in the directorate baseline of 4.5 million. It's a very welcome investment. It is allowing the team to do the great work that it is doing at the moment. And I suppose at its heart, it's allowed the downward trend to begin to take hold in the service in terms of dealing with those backlogs. And I'll hand over to Sandra.
Thank you, Kevin. So I think it's a real success story just in the last 12 months, actually, of our 1.5 million investment. As you can see from the presentation, at this point, 12 months ago, our waiting list was huge. It stood at 3,439. As of last Monday, and I'm still waiting for today's figures, and I'm hoping they'll be reduced further, we were down to 2,144 people. And that is a net reduction of 1,295 individuals waiting for an assessment. That's a huge commitment from the team. It's a huge look at how we work, how we've invested, how we've used the money. What it means is that fundamentally more people are now subject to DOLS authorisations and their rights are protected. So it will reduce the impact on safeguarding services. People will be able to have recourse to the Court of Protection should they wish it. People will have increased advocacy, and people won't be subject to overly punitive, restrictive measures in their day-to-day lives.
One of our other success stories is the waiting list times. They are very much improving. We recognise we've still got a way to go, but if you are looking at the longest wait at the point where I was here last year was somebody had been waiting for 2,226 days. I think it's come back down further from the 748 days. What I'd like to do is to reassure committee that if somebody is at high risk, we see those people and we assess those people within a very quick wait around. People are not waiting days at that point to be assessed. If people are at high risk and are objecting to what's happening for them, we are there very quickly. All of this is taking place within an increasing number of referrals coming into the service. So I've been with DOLS from the start of the legislation, where we maybe received 50 referrals for assessments a year. We're now receiving 180 plus assessments a week requests. So it is running all the time to catch up. Next slide, please. So yes, that's just what I was saying. So, but the long-term trend currently really shows that although we have this rising incoming workflow into the service, the numbers of people needing our assessments, the waiting list is now significantly reducing. So we're very, very proud of that. Progress on looking at assurance and structures and practice around community DOL work is ongoing. We're looking to see what the barriers may be for people getting applications into the Court of Protection, what might not be happening within our workforce, so how we can support the workforce to increase those applications so that we're not just covering people that are in hospitals and care homes. That's all ongoing and quite actively being worked on at this moment in time. We are always a service that prides itself on being a learning part of the organisation, so our staff are always at their heart. Social workers, OTs and nurses that work within our service are all about protecting vulnerable people's rights, making sure that people who have little or no voice and lack capacity to be able to express what's happening and what they feel about what's happening have a voice. So we provide this essential voice. I think we learn all the time. Fortunately, we have very few complaints given the number of work that comes into our service. I think that shows that we're a learning and responsive organisation rather than reactive. So yes, I think everything's going in the right direction. Next slide, please. There are challenges. There's a best interest assessors. It's a specific statutory role to undertake work under the DOLS legal framework. There's a national shortage of best interest assessors. We are managing that by looking to grow our own. We're recruiting people in to train. So we've got, not only we're trying to attract qualified staff already, we're also trying to attract people who would fit well with that line of work. And one of the other things that we like to do is benchmark ourselves against our peer and neighbour authorities. Unfortunately, there's a significant lag in NHS Devon reporting, so we haven't seen yet the figures for not just, you know, we're now coming up to April of this year, we haven't even seen how we benchmark against our neighbours for last year. We're expecting that to come through. Next slide, please. Was that it? Have we done? Lovely. More than happy to take any questions that you may have.
Thank you, Sandra and Kevin, and well done for reducing the number of people on the waiting list and reducing waiting time. So that is really, really good news. So well done for that, and to your teams. And hopefully that can be minuted. So that's really good. Thank you. Committee. Councillor Ketchen.
I think it's phenomenal that, you know, people have been waiting for up to 7 years previously to get an assessment. I can't imagine what that means for someone's life, that you have this question mark hanging over you. That leads on to one question. I've got another as well. What is the context of people who are waiting 2 years to get an assessment? What is the, just to give us an understanding, who are these people? Is it, we're talking about people in care homes and there's a sort of in changing lives, or, you know, at the point an assessment is triggered, and then 2 years in anyone's life journey, that is a long time, particularly if you do have dementia, because it's a progressive disease. It's not a line in the sand. So can you give us an understanding of what it means to be on the waiting list for 2 years? And then my second question is about agency and locum staff. You've got a what looks like a predictably increasing demand now, how much of the work that you've you've peak-lopped the real long waiters, you've sort of turned this around. How much of that is based on dependency with agency and locum staff? And is there a target to then bring costs, control costs by reducing agency or locum staff?
Absolutely. I'd like to reassure you that if somebody is on the waiting list for that length of time, we've, at the point where we receive the referral, we have triaged and screened. They should already be known to the organisation, so their care planning, if you like, will probably be reviewed under the Care Act. So we're not just leaving people, and it may seem like languishing, that's not the idea. So those people would be screened and triaged as relatively low risk, content. They may be people that had capacity when they went into the care home, chose it themselves, chose it with their family, not displaying any behaviours that would indicate that they're unhappy there or wanting to leave. The thing about this piece of legislation is the threshold for who's deprived of their liberty is incredibly low. So if you don't have capacity in relation to being able to make decision about where you live and the care and support you receive, somebody would be aware of your whereabouts throughout the 24-hour period, and you wouldn't be free to leave and live somewhere else. You are, by definition of the Supreme Court, deprived of your liberty. Now, that might be someone with a dementia who's very, very happy. At the same time, it might be someone with a dementia who's at part of their illness where they are really quite confused, quite agitated. We would not be leaving the person who's agitated, unhappy for that length of time. But just to kind of reassure you, but there's undoubtedly what we would like to do is to see everybody within our statutory timescales, which are 21 and 7 days. But we haven't, since the Supreme Court, been able to reach that, and people generally don't nationally. So I don't want you to think Devon is in a worse position than anyone else. I think we potentially were, and with this investment, I would hope that we will be flying up doing it better, if that makes sense. To answer your first part of your question. In terms of the second part of the question, agency and locum staff, what we've had is we have had permanent recruitment into the service to manage the incoming, so those 180 referrals a week, and we have used some of our own staff who wanted to work additional hours, plus some agency staff to do the back end, the waiting list end, so to try and reduce the length of time that people are waiting there. So our plan would be that actually at the point where we can catch up with the back end, if we're doing both things, hitting it from both sides, if you like, by the time we've caught up with the back end, we will no longer need those agency staff. So we will be able to look to reduce costs there. We need to manage our incoming with our permanent staff. So the modelling is all based on how many permanent staff do we need to continue to manage our incoming work over the next 3 years, and how many agency staff or non-permanent staff would we need to reduce the waiting list to the level where we can then manage it for our substantive provision.
You give a sense to the committee of what the ratios of agency or locum work are currently. That we get the concept, which is good, and I applaud your rationale. I think that's how I would look to do it when you're sort of in a situation where there's 7-year waits. But what can you give us some idea of what percentages of staff or agency and how much overtime this is? Because we're here obviously to scrutinise standards of care, but also costs.
So what I can say is that currently we're coming in a little under budget. So percentage wise, I wouldn't be able to give you the exact figure, but what I can say is that our main staffing numbers are now at, for our best interest assessors, 22.5 full-time equivalent staff. And our agency work, we currently have 3 full-time equivalent agency BIAs, and our own staff are working additional hours on an per assessment rate. And we're currently doing about 40-50 assessments a month, including that staff too. But I could certainly get you the percentages. I'm sure someone in management information could work that out for me, but I don't know off the top of my head.
Thank you. I'm pleased you're able to speak confidently about giving a voice to those who are less able to represent themselves. But on the deprivation of liberty, is there an independent or a disinterested assessment of your own judgment on that case, so that liberty is continued to be withdrawn if they can't express themselves well, and that they might want freedom from that.
I think the best interest assessor and the independent doctor who go and see people, that their job is to see. So they are independent. In effect, they're actually kind of independent from the local authority. They're little courts on legs, if you like. They go in and they assess, actually, is the person deprived of the liberty? Is that in their best interest? Is it proportionate? Is it necessary to the risk and likelihood of significant harm? So I think in terms of that is exactly the role that these staff play. Their role is to independently assess whether what's happening for the person is right and proper, if you like.
Councillor Tilsley.
Chair, looking at the stats, it seems like an incredible value for money, the amount that you've managed to improve waiting time. So absolutely commend you. Thank you. Is capacity the main barrier now between improving further, or is there something else we've not touched on?
Yes, capacity would be our barrier. Even with our levels now, we may struggle to get to a point even within 3 years of less than 1,000 people on a waiting list. So yes, capacity is always our barrier, but it's not just capacity for the things that we can control. It's capacity around independent doctors, it's capacity around specialist independent mental capacity advocates and Rule 1.2 reps. Also capacity around the court of protection and how quickly we can get. So we're just one part of a very big, not always very well-fitting jigsaw, but we're always looking for ways to improve the individual's journey.
Councillor, thank you. Councillor Morgan.
I was going to ask something around that, because you mentioned something about you're managing the incoming work at the moment to bring the waiting list down, so you'd have fewer agency staff as discussed before. But you said that in your experience, it went from 50 cases a year to 180 per week. So how can we be reassured that it's going to be future-proofed, or can't we?
I think it's really difficult to reassure you on that count, unless there is a change to the Supreme Court's ruling around what a deprivation of liberty is. And there is currently an appeal by Northern Ireland in terms of was that too strident, if you like. I think the argument for that wasn't necessarily as strong as it could have been, and I'm also not sure from a social work point of view how I feel about anything changing around the threshold of what is a deprivation of liberty, because even if you are content, even if you seem happy and content, if you have little known voice and the threshold is changed, then who's going to be checking that? And fundamentally, that's role of the best interest assessor. So what I would assure is that actually, if we can meet our incoming, and we may not be able to long term if it continues to rise, and the waiting list has been significantly reduced, I would hope our core staffing is enough to manage this without this end increasing. But I guess we just need to keep it under constant review.
Thank you. Councillor Rogers.
Thank you, Chair. I declare I'm a postmaster, and I've seen residents deteriorate in their physical and mental capacity, and I see scammers circling. Unfortunately, we live in a world of scamming. What I'm satisfied with as a postmaster, I navigate people to PACE, pre-check authorization, where they don't need a PIN number. This is a journey, isn't it, for you guys to come over. I applaud your service, and your service has been great support to me as a postmaster, where I navigate with families, making sure those vulnerable residents are protected. What I will do, Chair, is I will send you some information, because that list is worrying, but it's great work you're doing to reduce it. But I do see the scammers picking up on this within Devon and nationally. And there is a way you can get some quick wins to make sure those people are protected, their finances are protected. I think it's important that using the post office is a network that will help you. There are systems in place to check pre-authorization where people will not get scammed, because we live in a scam world and there are safeguards in place. So are you aware of that as officers of the pre-check authorization?
I think that might be to do with things, it's probably about community-based things, but it probably fits more with our safeguarding service. So I think you might be talking about people being scammed out of money and financial. So the deprivation of liberty safeguards is concerned with people who lack capacity in relation to where they reside. And it's not necessarily their money, but it might be information that would be useful for
The point I'm making is, as postmaster for 11 years, I've seen the journey where people have had to give up their liberty. They got into a nursing home, but the safeguard protection of finances hasn't followed them as quick as it could be.
So in Devon, we have a Court of Protection Finance team, and it may be that that might be a useful link for us to build. And also Sarah Mackworth heads up with our safeguarding, which is under the Care Act legislation. So I think that's probably where that sits.
And the banks have got a duty of care to make sure those
Absolutely
individuals, and
Absolutely
even though banks are closing, I think joining that jigsaw is so important.
Absolutely. And I think it sits within our safeguarding programme.
Just to confirm that absolutely it sits within the wider kind of community safety, the trading standards, and also the safeguarding arrangements, and it's something that we've raised previously as well. So again, more than happy to keep those communications going in terms of how we support people within the community.
Thank you. So my question, so obviously there's great work and the backlog is coming down. However, as of January 26, we do have 2,749 people, and I mean that might have changed slightly since January, waiting for assessment. So there is risk to the council associated with that waiting list. And I think what I would be interested in seeing is, I understand that we're just a part of the overall system, but to see some kind of trajectories from how we can actually bring that waiting list down further, so that we can be assured that the risk that sits within the people who are waiting beyond the statutory timescale is coming down, is continuing to come down, that we're not going to slip back, but we're moving forward. So I don't know whether that will be something that you would be able to produce for us as a committee.
Yeah, just to give some reassurance, we are working with our management information teams to actually look at that point at which we would break even in terms of both the incoming and the outgoing work, as it were.
Yeah.
And once we have the national benchmarking data, we can feed that into the system and we can give some data detail back to the committee if that's what you would like.
Yes, please. Thank you very much. Councillor Dawson.
Thank you. All the points I was going to make have been stolen by all the other councillors. So I'll just add to that request. Actually, it'd be really good, I think, as a committee to hear some more personal, non-identifiable kind of summaries of people who are waiting up to 748 days. And I appreciate it was over 2,004, but it'd be really good to understand that as risk, because the data is really important. But I think, as Councillor Ketchin said, there's a personal price to this, and there's personal situations, and as councillors, it'd be really good to kind of get a real deeper insight into the personal impact of that. Thank you.
Absolutely, we can certainly do that. We could also offer a masterclass, I think, so that new councillors could understand this piece of legislation and what it means and how the individuals might be affected and rights protected. I just want to reassure again, though, that people may still be on the waiting list far too long, but we would be re-screening and re-triaging at regular intervals, and we'd expect the care homes and the hospitals to contact us if the situation has changed. And indeed, our social work colleagues from our community health and social care teams will get in touch with us. So if the person's situation deteriorates, we have mechanisms in place to be informed, and then we can respond. So we don't want anyone languishing with high risk.
Thank you. And just to add also, not just that personal impact of that person about which the DOLS is being considered, the person on the waiting list, but also the professionals that are supporting them as well, and what impact that has on them and maybe the risk to their organisation as well. Thank you.
Thank you. I'd just like to ask Peter Hay if he would like to come in at this point. Thank you, Peter.
I'm going to have to get faster with my fingers, aren't I? I think what the report shows is the clear investment and attention that you've put into this area and sort of backing the priorities. I think, as the team have made really clear, there is further work to be done. And I think, again, what has come across this afternoon is a real sense of, or this morning, is a real sense of grip on what that improvement is. And I think it would be good to follow up with some of those kind of understanding the impact and just making sure that as you continue to make improvements, you're focusing it on the right groups, if that makes sense. So I think that's kind of what's next for you. Sounds awful after all that progress to be saying, and now do some more of it, but there's more to be doing.
Thank you, Peter. Any other comments, questions? So I think, yes, thank you very much, officers. Really helpful, really good news. And yes, please, can we have, I would support the recommendations, but also please, can we have a kind of trajectory as a committee, including the lived experiences which Councillor Dawson highlighted. Should we propose that? Thank you, Councillor Morgan.
Happy to say.
Thank you, Councillor Tilsley. Should we go to a vote? Thank you. Thank you very much. Thank you very much, officers. Okay, so item number 10 is the end of life care task group. Have we got somebody from? Thank you very much. Welcome, Karen, Barry, and Emma Bagwell. So we have your report. Thank you very much. And I don't know if you want to make any brief introductory comments.
Yes, I can do. Thank you.
Thank you.
Thank you. Yeah, and thanks for inviting us here today. So it's great to be here. We thought we'd just give. We've done the report obviously, but just sort of summarise the key areas from it. But just a bit of an update on the end of life work since the Task and Finish group put through their recommendations in January 2025. It's been so I've been working on this for about 9 months now. So it's I'm new to this to end of life as a working area, but Emma has a lot more experience than I have. So what we thought we'd go through, we'd like to go through sort of a bit of an update, but also Emma's going to share a story and a pilot that she's been working with, and also I've got a bit of an ask at the end if that's okay. So we've over the last sort of 12 months or so, we've been there's been some work on from a financial perspective on equalising the funding for the hospices, and I think that's something that there was very different investments in different hospices across Devon, and that has now been equalised. So whilst it's not all of the funding, obviously we'd really like to fund everything, everybody's getting equalised funding across the hospices in Devon. We've set up an end of life oversight group, which is multi stakeholders across Devon, and really tried to focus on what we can do in improving the end of life care in Devon, but within the limited sort of resources that are available to us. We've had, since the end of life task group recommendations were published or shared, there's been, obviously we've now got the 10-year plan and the Devon health and care strategy, but really supporting the end of life work is the 3 shifts within the NHS 10-year plan around moving from analogue to digital, treatment to prevention, and acute to community. And we really hope with the work with the neighbourhoods in particular, that'll be a real it's a real priority in the neighbourhood framework that was published last week around real focus on end of life, which was great news for us. We now have an ICB executive lead, Penny Smith. She's the Chief Nursing Officer for NHS Devon, and she would have been here today, but she's actually not in work at the moment, so was unable to make today. We've now also got within each of the localities, so across Devon, we've established working groups to work on the local issues and the local delivery of the sort of like the strategy around end of life. And then wider across Devon, we've really had a focus on some key areas that we think we can really make a difference around. And one of them is around early identification of people approaching the end of life. And we have reinstated a task and finish group working on how we can really focus on that at the moment and make it a priority for this year. There's been a lot of work on aftercare, after death care, standardising the approach across partners, and that's been a piece of work that's just coming through to the finalisation, and that will be published in the next couple of months. One of the things that, and it's been really an interesting from my perspective coming into sort of this work, is around end of life medication. So there's been, and we had a group which met last week, and we really tried to understand the real issues around the fact that people can't get access because the pharmacies are closed, and also the timeliness of access. We really have sort of made a real commitment as a team, as a sort of a task and finish group, to really get to the bottom of that and to try and look at how we improve that moving forward. So I'm sure you'll have, you might have heard the Devon and Cornwall Care Record, which is a sort of shared record across health and across health and social care, and even into care homes. And in the last 12 months, we have we've managed to sign that for the longer term. So that contract has been, which means, that the Devon Care Record improves communication across teams, ensure access to care plans, etc. But that all the people involved in somebody that's at their end of life has access to that information. And in particular, and this is where we've really started a task and finisher group, is around electronic treatment escalation plans, which shows people's preferences for their end of life. And there's been paper, what they call treatment escalation plans, for a number of years. And in the last 12 months, we've now sort of implemented an electronic version of this, so it makes sure it's up to date. Excuse me, and everybody who needs to have access, as long as they've got access to the system, can see these plans. We had and again, we did a working group on this a couple of weeks ago, and there shows there needs to be some real consistent approaches to this, and we have made a commitment again to really try and make a consistent approach and consistent documentation. There's different documentation depending where you live in Devon, which then makes complexities. If somebody from North Devon goes into Exeter, it'll be different paperwork, and that could cause some problems. So the task and finish group is now set up, and as I say, working on ensuring consistent approach, standardised documentation, and all care settings have access. Over the last 12 months, all trusts are now live. RDUH went live at, I think it's about in the sort of the autumn time last year, which is great. The South West Ambulance Service is now live, and the majority of practices are now live as well on that system, so they can now get access to the what called ETEPs. We have got some practices that haven't. They might have access to it, but they're not necessarily using it. But that's one of the things that we're trying to really push now over the next 12 months, to just get those last few practices on board so everybody has access. I'm not sure if you're aware, but and it's in the slides, but in 2026, in the autumn, there is a national modern service framework for end-of-life care being published, and that's making end-of-life a real priority as part of the framework for this year. And they've got, I'm going to just sort of just read the moonshot. It's a moonshot, which is the sort of, I guess, an objective. By 2035, every child, young person or adult will have timely access to high quality, sustainable and personalised care and end-of-life care delivered in any setting shaped by what matters to them, their families and carers, so they can live well and die well. And I think it's really great to see that we're getting something pointed and something we really need to work towards nationally, but how we then locally pull together as a group to move that forward. And really working on the neighbourhood health and the focus of end of life and frailty. So if I can then hand over to Emma, who can put this into life.
There's just a few slides at the end of the presentation. They're slides 8, 9 and 10 to deal with a test of change, one of a few test of changes we're trying. And this is around a slight bit of workforce redesign, because we've got a financial envelope we need to deliver a service to, and so we have to use what we've got. But one of the questions I had was actually, we do MDT working, we work with primary care on trying to identify people at the end of their life, but it wasn't really coming together. So I just asked the question, actually, if we had one lead in each team, would that make a huge amount of difference to recognising people that are last year end of life and preparing them for that stage in their life, but also prevent unnecessary hospital attendances because they have increased, and also could it reduce the amount of people that die unnecessarily in hospital and not achieve their preferred place of death, which would be at home. So we set up a test of change in Torrington, where we just had a budgetary vacancy that we could work with and work in a different way. And we had an end of life lead, paying particular attention to not making them an end of life specialist care, because actually end of life is everybody's business, not just one person. It was very transformational for the team. They learned a lot. They learned a lot about systems and processes. They learned a lot about their relationships with the wider MDT, including primary care, the hospices, and actually how do they work together. And they worked a lot with patients, identifying frail patients that are in the, wouldn't be surprised if they passed away within the year. They work with families, relatives of those patients to understand actually what are the wishes, and having really good conversations about death and dying. And actually the results, within a year is we had reduced admissions to hospital, we had increased deliverance on preferred place of death, and we had some very grateful grieving relatives that were able to care for their loved ones at home, which was the right place for them. We had really good relationship with our partners, enabling us to deliver it, and we did that via something called Advanced Care Plan, which is a national tool, but actually it's bringing it to life, and being able to have those conversations at a pace suitable for people, because a lot of people aren't used to talking about death and dying. They're talking about living quite a bit, and actually it's okay to talk and to display your fear and have a bit of control in how that's going to pan out when the time comes. So we had some really good results from that, and we're actually progressing that to a permanent arrangement in Torrington, and now looking across the rest of our services to understand when we can roll that out. And we're working with the trust on that to understand how we can deliver that. Slide 11 is sort of a story, and it doesn't come from Torrington, it comes from another area of ours, where we've got high complexity of young people with complex needs who are approaching the end of their lives. And it's a story for me that represents how MDT working really works once you realise someone is coming to the end of their life, and how you are able to deliver good quality end of life care with a wide range of professionals, including palliative care consultants, to deliver really complex palliative care to someone who's young and is dying. And what was really amazing about this experience was that her mother said she didn't realise that you could look so good and look so peaceful when you've actually passed away, because her previous experience was not that. And from a grieving point of view, that's helped her and her mental health immensely. So if you get it right, we know that actually it helps more than the person achieve their wish of where they would like to die, but actually it helps a whole body of family cope with losing their lost one, their loved one. And again, the ACP and the understanding of the wishes and really advocating for that patient, and protecting the safeguards as well, and making sure there's a legal framework around it was really important, and it worked really well. But actually, it's also a recognition of how much time that took of people. It's nearly a whole time equivalent of a band 6 would have if in all the participations of the MDT. So it's quite intense in how we deliver it. But it's absolutely the right thing to do. So those were just really good. That was a really good story for me. It's happened a few more times, and it just displays the flexibility in the working arrangements across and with all our partners. So I just wanted to share that with you.
Thank you very much. Thank you, Karen and Emma. Members. So I've got Councillor Ketchin, then Councillor Davies, then Councillor Dawson, please, and then Councillor Rogers.
My understanding is that nationally palliative care is not funded by the government yet. And there was some debate about it in Parliament about a year back. Is that still the case? And can you tell us how services will be funded? I noticed there's a aspiration to have a 24/7 end-of-life care service. I mean, that is a very high-end ask of a service. So yeah, where's the funding coming from? Is it nationally funded or is this from within budgets?
So it's within the budgets with the, if you're talking about palliative care within the trust, that would be within the budgets of the contracts with the trust. The palliative care within the hospices is partially funded by the NHS and then partially charity funded. And there are some other contracts which are sort of partially funded by the NHS, but we haven't been told what's coming with the modern service framework. We haven't been told whether there'll be any funding associated with that. We hope there will be, we really do. But there's nothing that we're aware of yet. But as I say, it's being launched in the autumn. We thought it was going to be launched in March, but that has been delayed at the moment, I guess, while they get the sort of the details agreed.
Thank you. And so I think if we could just, before we go to Councillor Davies, go to Peter Hay, because I think he may have to leave shortly.
Thanks, Chair. I mean, I think there's been some good work going on, but I think that what for me the kind of core issue here is it almost links to our earlier debate, really. Actually, how does the health and care system use the capacity of the council to achieve change? And I think, despite the positives in the work being illustrated, there's an opportunity here to move at scale. And I think what is, and this links to, I think, the strategy conversation we were having early, what the scrutiny review showed was the appetite of the council for significant and substantial change, including potentially reprofiling resources. So I think that the challenge is here is how do you scale up that potential for change really quickly and deliver the kind of ambitious whole system wide kind of opportunities that are offered at end of life. So that sounds like a bit, but it comes back, I think, to that earlier debate, and I think makes a reality of strategies about changing the experience of end of life at scale over a tight time scale. And I think that's what's missing at the moment. And I think that's what would be really helpful to try. And this is really illustrative of some of those challenges, and is perhaps an area to use, because if nothing else, it also shows the council's real appetite for significant change in people's experience at the moment. That's helpful.
Thank you, Peter. Councillor Davies.
Thank you. Yeah, I'd like to just draw your attention to the document in as much as it's a very aspirational document. But I can tell you in my own experience, we're failing on all these points. And I do this every weekend, talking to families who are having problems with their member of their family who's dying, and JIC med's not in place, or the syringe driver's in place, or the district nurses can't come out, or oh, there is a drug chart, but there isn't a syringe driver. So all these problems, which could have been sorted out by the GP earlier in the week, are left to the weekend. It's where the out-of-hours doctors are then sorting a patient. The care records, there may be a TEP plan, you're right, there might be, but it might not be on the system. So there's a lot of issues which are still happening every single day in Devon. So this, as I say, it's an aspirational document and it's great. We know that there's not enough hospice places, but I'm not sure that's such a focus, but because I think in my own experience with family members, people want to actually die at home, not in a hospice if they can, if it's manageable. The point that I'd like to make mostly is about the recommendation 4, and that's about supporting members of the family, because I find that in a lot of times, end of life situation, if the patient is well provided with medication, then it's actually the family members who we should be supporting, because it's a very, very distressing time for them. And I feel like more emphasis needs to be placed on that. So it's not a criticism, it's just to say that this is happening in Devon every day, sorry, every weekend.
Karen.
Thank you. I totally agree, and I don't think there's any doubt that we could do better, and a lot better than we are now. And that certainly came out with the workshops we ran in the last few weeks, where we really got all the really knotty issues out on the table. We haven't got answers to everything, but we absolutely want to do things together with all the stakeholders to improve for families and for the loved ones and for the person who's at the end of life. And I think one of the asks that I was going to bring to this meeting, or we were going to bring to this meeting, was we really feel that there's a lot we could do to prepare people for dying, prepare the families. And there's in May there's a Dying Matters Week that Hospice UK, and I've asked our comms team within the ICB, and I think what I'd like to do this wider is how can we do a real sort of push on making sure people and their families are prepared for dying, because you can die well, can't you, and you can die badly for your families and yourselves. And there's so much we can do if we start talking to each other as families. I've personal experience of this recently, where I've started to really start thinking about helping my parents prepare and make sure everything's in place. And I hadn't even thought about it previously, but one of my parents was poorly, and we thought wasn't going to make it, but did, really luckily. But it did make me think, gosh, what if this, what if that? And I just hadn't realized how much we don't talk to our people, our families, what we want, what we need, how we want to die, how can help everybody to make it the best experience it possibly can be at such a difficult time. So absolutely committed to working with all stakeholders and all the councils, etc., and also the voluntary sector. There's so much voluntary sector can bring to us.
Councillor Davis.
Sorry, I just wanted to come back on that just to say that in the out of hours doctors over a weekend, you could have a patient who's down for an urgent call for end of life medication, and that could turn into a 8-hour, 10-hour wait. That is an awful long time for a family to sit and watch somebody suffering. And we need to address it, really. So.
Thank you, Councillor Dawson.
Thank you very much. Yeah, I really welcome all this work. I'm away from my council life. I'm a mental health nurse and I run non-NHS and I run free bereavement service, which is really interesting to hear what people's experiences have been, both at home and hospital and things like that. It's quite insightful and sometimes quite difficult to hear and quite difficult to help someone kind of travel along that path where you've got unresolved issues. So yeah, I think when you're talking about sort of that preparedness and management of expectations and really the education with family as well, particularly around medication and what, solving this problem in the last few hours or days of death causes this problem, we need to then manage that, that kind of tricky balance for comfort. So yeah, I appreciate all the work you're doing. I'd be really interested to hear who the stakeholders are in the end of life group that you talked about and in the working groups and also in the task and finish group. So what people are you including in that? Is there anyone unusual? What's the justification for who's in that group and what do they bring? Thank you.
Sorry, so it is a wide group. They're all sort of different wide groups, and it's been about people that wanted to be part of the groups, I would say. But we've got the hospices, we've got voluntary sector, we've got the hospitals, we've got the ICB, obviously, primary care. And I've been sitting thinking, have we got anybody from Devon County Council on those groups? And I think there is on these locality groups, but I'd have to go and check, to be honest. There is, sorry, you know better. You want to?
That we engage with all of our system partners, so it's dealt with from probably social care point of view, but also we have got a patient rep as well, and she's really good and helps us think about things in a different way because we get into professional speak and we sometimes lose the plot, whereas she brings us back to actually, you know, it's about the relative, the patient. She talks very openly about the patient, who the carer's looking after her husband who has dementia, and she brings some interesting reflections to the group. But end of life is what I would say is end of life is a system partnership, and you need every single part of that system to work perfectly in order to deliver it. When it goes wrong, it's like Swiss cheese. It will go wrong in every single direction. And it's tragic to see that when that happens. But we are looking at actually what can we do within the resources we've got. So in the case I was taught, in the case the story, we have got prescribers in the team, and they manage that patient through out of hours and through the day. We didn't call the out of hours because we had a really good plan. So we know if we have really good plans, we have the right people with the right skills, you can deliver really good care. But actually scaling that up is where the challenge comes, and scaling that up at pace is where the challenge in particular comes.
Thank you. Just a little supplementary. So it's good to hear that you have a patient rep, but how do you go about, or you might already have things in place where things have gone wrong or where they've gone right? How much of that experience is captured? I know it's a really difficult time, isn't it, to say, hi, I hear your husband died recently. Can you rate us 1 to 10? But how do you sensitively gather that really valuable information about what people's actual experience has been, either whether there's been a service present or hasn't, whether it's gone well or whether it hasn't?
So we do bereavement visits. So after anyone who's known to us, not everyone is known to us. So anyone that's known to us, we do a bereavement visit, and we cover off what went well, what went wrong, even better if, and we bring that back to professional forums. Or if it was really troubling, what was not, or even better if, we would bring that through our complaint system, so we can actually look at our systems and processes and think about actually what can we change here to make sure that doesn't happen to someone else. And we do that consistently with everything we do, but particularly with end of life, and we've got some really good data around that, about how we share stories through our governance systems, and how we change things. We've also got our clinical effectiveness tool, where we go and we review documentation, because actually if you follow the 5 priorities of care, you should have covered off all of that, and there shouldn't have been anything lacking to an extreme. And we are currently working on how to improve delivery of the 5 priorities, and that will highlight issues early enough as well. It should do.
Thank you. I think Tandra wanted to, oh, Donna, sorry.
Just, thank you for being here. And I think what Councillor Davis said, we really need to take on board. And when it comes to that case level and saying how challenging, if we start first from that strategic level, just thinking of children's, we don't have a children's hospital here in Devon and Cornwall. And I just need to say a number of residents have expressed to myself in that role, why is that the case? So, I think starting there, when you then begin to recognise that specialist support that's required, and then what you've talked about in this is how you build that confidence in locality teams. It's often that access to that specialist support that gives that confidence, gives that assurance, and creates the ability to do things differently at home. So I think that's just a marker I want to put down to the committee. That's always been an interesting question, because when you then look, and if you've been involved at case level, the impact this has on families when they're losing a child, and the impact on the siblings. And then you begin to think about, if I'm travelling from, and I'm glad you did you're doing Lucanton and Torrington, but you can imagine that journey from Torrington, and then how do you get support around your family, and then how do you get one child maybe to specialist access, and so on and so forth. Absolutely, the level of trauma and challenge for families really is unbelievable because we're on a peninsula. If you then look at other families across the country and just look at the transport networks, then that challenge is then not the same in terms of what it means. So I think this is a really, really important issue. And I think there's something more that we have responsibility for this because, you know, the national reforms, and I'm glad the Cabinet member for social care, children's social care here today, because if national reforms are families first, you know, and so when you look at this vulnerability, often you think about social care and you think about kinship arrangements and so on. There is a real opportunity in family first reforms to look at this differently. There's new levels of investment and funding coming in, and I just don't think we're cited enough on this area of work. So I really welcome this today, but I would ask the committee consider whether there's a further recommendation that tries to join the dots on this, and then to see, I mean, test and learn is fantastic. That's where innovation comes from. That's where people begin to behave differently and carry out their work differently. And I think there's something in this that should be pulled up to scale to recognise what a challenge this is. And I've used children as an example because I've had so many families express concern about this area to me in the time I've been here. But I do think there's something about how do we lift this up into something, and as members, you begin to think about what this does look like for the future. I'm just not sure that it's right that any family needs to travel more than 3 hours for any form of specialist resource, or for staff in the front line not to have that access. So, you know, if we really want to grow our own, back to Councillor Ketchin's question earlier, it was a good question, and you did say it's about making a difference for families and it's delivering best value, and yet you've been asking questions as a committee today about agency. Here's a prime example where those two things together, we really need to think differently in our peninsula. So I'd just ask you to consider that in more depth, please.
Thank you.
Thank you, Chair. I've got a couple of questions. Thank you for the presentation. You mentioned the funding gap in end of life. What is missing then? So if I want help and support as a family member, you mentioned the gap. What is the detail of that gap that's missing that you need our help to try and fill that gap? Question number 2, and this is the tell us once process. So when this family member sadly passes away, you know, I as postmaster constantly promote the tell us once, and that's a really good service to help the families who are going through grief. And can we openly talk about that, and do you aware of tell us once? And question number 3, residents going with my division facing end of life challenges constantly say about the cost it's having on their, you know, budgets are really tight in households at the moment. And do we do anything for car parking where they're going back and forth to the hospital or hospice or place to get support for that family? And my final question, on the out of hours care, if someone at the end of life calls the out of hours service, are they flagged they've got to be prioritised? Because obviously the trauma those individuals are going through, and a minute seems like an hour seems like a day. And is there anything you can do on that?
Okay, so financial gap, I think there, if you, so hospices are only partially funded by NHS and the rest is charity. So I think there's always a big challenge, isn't there, with regards to that level of provision, being able to charity and raise enough money to be able to provide the services they really want to provide. So I think there's a gap there. And I think when I talk about hospices, I'm not talking about the beds in the hospices, but all the other care that the hospices give. So I think that's probably where there is a gap. And I really hope that there will be some money that comes down centrally to support palliative care end of life from the new modern service framework that's coming out. But as I say, I don't know what is coming yet. The tell us once, I've personally heard of it. Is it something that we've talked about in our group? in the groups that I'm involved in, probably not, but I think that's still around that preparing for dying and making sure everybody has all the information they need, isn't it, to make the journey through the bereavement journey, I guess, really, really easy. Well, not easy, that's not the right word, but as easy as possible for people when they're in that position. So I think that's, you know, this is the sort of thing that I think we really need to do, is what else is there that we can share. I'd love to see like a leaflet that said all of these things in it that people could have, and it was just out there. And I think hospice care do have some things like this, which I was looking on their website last night, and there are some things that we can probably just need to publicise more and make sure people are aware of. With regards to the car parking and costs, I don't think I don't know that you have to, I don't think you have to pay at the hospitals if you're at end of life. Well, certainly, no, you don't. So I don't know if you want to.
As far as I'm aware, for children and people who are in the end of life or in ITU, you know, coming to the end of the days, they do have free car parking. I'm not sure. I can only speak for North Devon and RD Royal Devon.
It certainly is for Torbay. I can find out whether it's at Plymouth, but I'm pretty certain if it is, it is. Yeah.
I think it's pretty standard. Yeah. Out of hours, so we have our out of hours nursing team, which is quite a finite, and we do provide 24 hours. That's not national, we found out. But we've got an end of life line, so anyone who is known to be in the last days of life are given this line to the nurses, direct to the nurses, and they'll come out. And those patients have usually got a plan. It's the ones we're not aware of that don't get that. And you know, we're trying to work out, and hopefully with primary care, and if we can start off the gold standard frameworks, which we've got a task and finish group for, we'll get to know about more of these patients, because there are quite a few we don't know.
Thank you very much. Quickly.
If they ring Devon Doctors then, which is the out of hours service, do they have a flag on their system that those patients and the families are supported at the end of life?
I would imagine so. So they used to have a system called Adastra, but the one Devon that we spoke about in the presentation, that documentation will also be really helpful. We all use it across the system, then you'll get the right information at the right time.
Thank you. Councillor Gent.
Thank you, Chair. Picking up on the remarks of our Chief Executive just now, is this something for the committee to take forward? I think the obvious thing to me is that end-of-life care at home can often be a lot less bad than at hospital, although that's not always the case, but in many cases it is a good thing. It doesn't happen just like that. What this report makes very clear is it's not like 200 years ago where you just die at home without any support. There's a whole lot of services that come together to make it work well. And I wonder whether the job of this committee is to ask the question, how can we make end-of-life care work better in Devon? And I have no idea what the answer would be.
Thank you.
Say, how do we make end-of-life care at home work better in Devon?
Thank you very much, Councillor Gent. I think, so we have a work programming meeting. We haven't got the date set. I think it's due to be at the end of April. And I would suggest that we look further at what we can do to enhance end-of-life care for people in Devon. We've heard some really useful comments, and I think that there is potentially more that we can do, but I'd like to explore that, suggest we explore that outside that committee, outside this committee in our work programming meeting. I would also request that that we have from the recommendations, they were from our council's task group, and it'd be helpful if we could have a response on those recommendations, the 4 recommendations, in advance of when we meet to discuss what else we can do as a committee. So there's recommendations 1 to 4. So if you'd be able to come back and agree or disagree or say why you think it's not practicable, that will be really helpful in advance of when we have our further discussions as a committee. But I think what I would say is I've really heard everybody's comments, and I think it is absolutely crucial. I've heard from the Chief Exec and from the members, and if we can, let's look at what else we can do, because it is a system-wide concern that but what can we do? So let's look at that in our work programming meeting, and if we could have, as I say, the recommendations before that, comments on them. Thank you very much. Any further comments? No, thank you. So now we've got the reports from, so we've had 2 visits. So there's the CoLab Exeter site visit and the Care Direct Plus Barnstable site visit. I will just very briefly say about the CoLab, because I was on the CoLab visit, but I couldn't unfortunately attend the Barnstable visit. The CoLab visit was really inspirational about the work of CoLab. But one thing that I would just highlight is that there's lots of different agencies and groups working together at CoLab in Exeter, but at the moment I don't believe there's anybody from adult social care at CoLab, and I think we've got all the different bodies represented, and I'm wondering whether we could look at having Devon there as well.
Thanks, Jess. Happy to pick this up. So there were some previous arrangements where one specific social worker was based directly at the CoLab. The operational team has changed the way that they're operating now, so that more than one social worker is supporting the multiple individuals that sit across the CoLab. So as of today, actually, the community services manager and the team manager have been visiting the CoLab again this morning to talk about how we make sure that regular presence is available, and an opportunity to kind of drop in to do the assessment. So that's what's been happening, as opposed to a fixed one worker approach. So lots of work is happening with staff in the CoLab, and adult social care are present and still actively working across that site.
So will there be somebody, so I think what's really great about that space at the moment is there can be one person visiting CoLab with multiple needs, housing, mental health. And so at the moment, people working there don't have to pick up the phone. They can just communicate really easily with all the other professionals in that space. So is that something that's going to be possible for Devon? So rather than kind of dropping in and making appointments, will there be a kind of constant, a permanent presence for representatives from Devon County in that space?
I think there'll be a regular presence of Devon County Council within the space. There won't be one social worker based at the building for a variety of different operational reasons, in terms of making sure we get the best kind of outcomes for multiple complex individuals who have different case managers there. But one of the things they've been talking about with the CoLab is around that use of our advanced practitioner role. So being able to have that regular communication and connection with the CoLab to do some training and joint learning as well, and a joint shared space. So it will look and feel slightly different to how it's been traditionally arranged there with one single social worker. But I think that creates a single point of failure in and of itself. So there's a bit more about how we create the working conditions to kind of work together across that through a variety of different settings.
Okay, thank you. Anybody else want to comment?
Thank you, Chair. Very quickly, the CoLab alliance model is wonderful, and the more anything we can do to promote that is great. The City Council is fully integrated into CoLab. I think there was 4 of them, and 4 of them working in CoLab building. Having anyone from Devon County Council working there would be absolutely wonderful. Just that integration was what every single person we spoke to said was the key to its success. Just people being physically accessible. So it sounds like we're moving in the right direction there.
Thank you. Any other comments? No. Okay, so, oh, sorry, Donna.
Just it is a fantastic resource. I think the issue of homelessness is an area for us as a council to possibly revisit in terms of all things possible. I know listening to Director of Public Health, and I see in the report that we're very concerned about the changing drug challenges that we're facing. I don't know if the Director would like to comment about it, but it has been a really challenging year in this space. So I know in conversation with the leader that strategic look across all our services at homelessness is something that is definitely an interest of the new cabinet, and they will be. The leader's not here today, but I know from discussions we've had that we've been asked to look at this as officers. So I just wanted to make that point, but perhaps it might be helpful to stress the importance of this, some comments from the Director of Public Health, because the annual report that members of this council would not have heard, but we heard at some point, was the annual report last year, was really quite shocking and worrying.
Thanks, Jess. And it's if people read the report, you would have heard back in 2015, the original funding for it came from Public Health, not local authority, but Public Health England at the time. And I note in the report, I didn't attend the visit, but I've been there a number of times. It talks about the changing drug markets, which I've spoken to the Scrutiny about and previous cabinet members about as well. We know there's a changing drug market, and we're seeing an increase in drug-related deaths, not just in Exeter, but predominantly in Exeter. At a high scale. So I think last year we had over 22 drug-related deaths, and this is much to do with the change in drug markets. So just very briefly, you know, the heroin market is reducing. The Taliban have stopped growing poppies, and therefore people with addiction will get hold of what they can. So the report points to synthetic opioids, so lab-based drugs, can up to 100 times stronger than heroin. And if you get bad doses of it, it can go around quite quickly. So we've had a number of occasions where 2, 3 or 4 people have unfortunately died, or that number have been brought back using naloxone, which is a injection to bring them back round. So a hugely challenging issue. I chair the Devon Drug and Alcohol Partnership, so we are working collaboratively with our broad partners, as you can imagine, and started again having a newer conversation with our colleagues in Exeter City Council about housing as well, around supporting this very complex group of individuals. While the numbers might be relatively small, you would see in the report the complexity of the individuals they're facing, and you can see the need for the multi-agency response to these individuals is so vital. And I point to you, we talk about inequalities, and it's in the report. You know, life expectancy for someone who's homeless can be, you know, early 40s, which is just shocking, I think, in terms of this day and age. So huge issue in terms of drugs and alcohol, rough sleeping, homelessness, mental health. But the complexities you see plays out day in, day out in the CoLab, and you know, it's featured as a model of good practice up and down the country. And you know, a number of eminent individuals have visited that place, including yourselves, of course, over recent years, to look at it as an area of good practice. So we cannot take our foot off the gas for it. We are in constant conversations with them, you know, increasing our offers around domestic violence and sexual abuse, drug and alcohol support with our colleagues in Exeter City and our NHS colleagues, and obviously colleagues sat beside me as well. Thank you. Thank you.
So I think, health inequalities and life expectancy and the shocking statistics around people experiencing homelessness who suffer an early death. I mean, I think it's one of those really complex multi-agency concerns that, again, with our work programming, I think we should be really looking at that, because Exeter is disproportionately, I mean, it's been singled out through the high level of deaths in recent years in a national report from the Museum of Homelessness. And it is that there are things I believe that as a committee that we really should be looking at, and homelessness and the impact on people, on Devon residents, is really, really important. So again, I would suggest that that's something that when we're looking at our work programming, that's something that we consider. What can we do as a subject matter in its own right, and certainly the visit from to CoLab and St Petrock's was hugely enlightening and concerning at the same time. So I hope that's something that we can have a look at together. Any comments, or should we move to? So the next visit was to Care Direct Plus, which is in Barnstaple. I couldn't attend, so I don't know whether Vice Chair Councillor Tilsley would like to comment.
Thank you, Chair. Again, an excellent visit. Really impressive things happening up in Barnstaple at Torview. The main issues that were raised was the workforce sustainability, especially in occupational therapists. It's being so remote, North Devon, they were really struggling to hire. They've had vacancies for many, many years, but we've talked about it before. So thank you very much. The actual building, Torview, is a wonderful space. Really, really excellent. And as mentioned in the report, the teams there really, really valued working so closely with other teams and really valued any input they got from senior managers travelling up. I appreciate North Devon is a very long way away, but generally really wonderful. The removal of pinpoint, I think, has been quite keenly felt. I think it was a relatively long time ago now, but they're really feeling it up in North Devon. And the main issue that came out from talking to specifically got the name of the team, but the team with workers being sent out such long distances. One of the practitioners we spoke to said she spent approximately 60% of her day travelling between appointments rather than actually at work. So we have a problem with rurality, but all highlighted in the report. Thank you very much.
Councillor Dawson.
Thank you, Chair. Yeah, it sounds like a really good visit, and I'm sad that I couldn't get there. It's highlighted something actually that was brought to my attention quite a lot before getting elected onto this council about the removal of pinpoint and the impact on people looking for carers, people being totally lost, people having to be, feel forced to go to agencies and things like that because they just didn't know where else to turn, and it's just left a massive black hole. So I think that's a piece of work that we really need to look at as well in the future, is what has been the impact of that and where have people been left, because lost in the dark is the message that I get from people. Thank you.
Any further? Should we move to the next item, which is the Health and Adult Care General Update? Thank you very much for this. I think I would just like to start by asking Sove if she could give us an update, please, on the link centres.
Yes, so the link centres were originally 4 centres in North Devon providing mental wellbeing support. So I think it's important to note this was not specialist mental health support. It was for people who were probably a little too complex to be managed within primary care, but not unwell enough to need secondary care support. Historic arrangement been in place, I think, since something like 1992. The previous committee had regular reports on the proposals we had to change the arrangements to effectively close the old service and replace it with a new service run by the Devon Mental Health Alliance. That's been in place for about 18 months now. It's going incredibly well. And we brought a report to this committee a while ago. I'm very happy to bring another update to a future committee. The service users got legal aid to challenge the decision. The initial and had a judicial review. That was overturned. We defended that successfully, and they went to the High Court 2 weeks ago. The High Court judgment has not been published yet, so I can't share any of the detail, and I don't know what the decision is going to be. However, we are hopeful that the appeal will not have been successful. I'm happy, as soon as that's published, I'm happy to share that.
Thank you. Any other comments? Any comments, sorry, on the the general update, or any comments from the officers or Councillor Keeling?
I would
only say that we have attached some performance data at the end of the report. So there's two sets of slides. One is a Living Well in Devon update, and I think we finally might have a date for the standing overview group, and the draft terms of reference we're very close to agreeing. So that's going in the right direction. So there's some slides there as an update so that you can see what's happening, and I'm sure Amy and Sauvé would happily answer any questions if you've got any on that. And we've got some data, some performance data, which was requested. I think we had a specific session, didn't we, to discuss it. And I've got Sarah Mackworth here if anybody has got some questions about that. But you know, we've got our four key priorities, which is around reducing waiting times, finding local solutions that promote independence, consistently delivering best practice, and working within our budget. So, and I would say that the Living Well in Devon, there are strong connections across all of those with the Living Well in Devon programme, and the data below just shows you how we're getting on. And I would say it's a journey, and we're doing everything we can. Obviously, you heard about the DOLs earlier. That's a key part of the timeliness, but we're also doing work around Care Act assessments, for example, client financial assessments, etc. So if anybody's got any questions, so we'll probably all pitch in, but Sarah Mackworth is here to respond to that report specifically.
Thank you. Members, any comments or questions on the composite update? I've got a question. So I was looking at the data on safeguarding practice quality review, and the fact that the reviews are shown as low and variable. So I think what that means is that when the decision making around safeguarding has been assessed, it's been assessed as variable, and I'm looking at page 13. So if you look at the number of reviews, so that's 125, 37, so that's 30% requires improvement, and that seems quite high to me, and I wondered why. So 48% are showing good practice, but 30% are showing requires improvement. And then if you look at overall ratings for safeguarding inquiries, 37% requires improvement, and I find that a little concerning. So I wondered if Sarah could comment, please.
Just before Sarah comes in, obviously 18% are outstanding and 21% are outstanding. So if you take the good practice and the outstanding practice, it's a significant majority, but you're absolutely right. This is all about proving quality of practice. So I'll hand over to Sarah.
Thank you. I mean, what I would say to add to that is that that's the overall position for all of the practice quality reviews over an extended period of time, which I think is over about 18 months. If you look at the most recent versions of the bar charts, the percentage of both concerned practice quality reviews and inquiry practice quality reviews that are good or outstanding is significantly higher. So for inquiries in the last month, so the last month cited is December, 83% are good or outstanding, and for concerns it's 78% that are good or outstanding. What I would say also is that this is a kind of ongoing barometer of the quality of our work, and at times we will target different cohorts. So if we have an influx of new staff, we'll use the practice quality review process to gain an overview and to use it for learning and development for that cohort of people. So it's a kind of positive thing that it varies over time, because we're using it to target against different cohorts of staff. And for our safeguarding inquiries, we're using it to target different cohorts of risk, for example. So it's not a bad thing that you see variation. Overall, what you would want to see is an improving trend over the period of time. And I think we see that if we look at the sort of fluctuation at different points in the kind of annual cycle of practice quality reviews. We've put this in because I think it's really important to have a focus on quality as well as timeliness. We know we have some challenges around timeliness, particularly at our safeguarding front door, but I wanted to assure the committee that we've got just as much focus on the quality of work as we have on the timeliness of response.
Thank you. And do you think we're doing enough practice quality reviews?
No, we'd like to do more. And we have got a programme to drive up the number of practice quality reviews that we do. So for safeguarding concerns, it's probably closer to where it needs to be. We know for our safeguarding inquiries, we need to do more of that work, and we have a process in place at the moment to drive that up.
And how much is it going to go up by?
Well, so the target for safeguarding inquiries is that each team will do one safeguarding practice quality review per month. We've got about 25 teams that are in that kind of cohort, so we should see 25 safeguarding practice quality reviews a month, and we have started to move towards that. So from a low base of about 4 in July last year, in recent months, so January, February this year, we are starting to see an increase to 11, 12, which is double the low point, and it's about half of where we need to get to.
So when do you think we'll get to a 25?
We have plotted a trajectory. It tends to work on the basis of historic performance showing your trend, but we should get there within 3 or 4 months.
Okay, thank you. Committee, Councillor Dawson.
Thank you. Just a little question about complaints, and it so item 354. It says about 197 complaints received between April and December 2020. Sorry, I think I have no voice in a minute. So 197 complaints compared to the same period 24-25 when it was 149. I know it says that you're doing investigations to look into what's caused that spike in complaints, but I'm wondering if we can have any sneak peeks as to thoughts or insights as to what might have caused it, please.
So we haven't got Helen Wyatt with us here, so I would suggest that we can ask for a response outside of the meeting. I wouldn't like to speculate, and I think we just need her to respond on the data because she collects it.
I'm sorry, Chair, I should have probably just been patient, and because it does say they're investigating, but couldn't help myself.
Thank you. And I think one thing I would just also say that it's not in the composite report, but it has been an ongoing issue for the committee that we've been looking into, and that's around the fire co-responders. So concerns are being raised with me about the revised impact assessment and comments made. So I will be writing back to South West Ambulance Trust again about the quality impact and the way that they're proposing to change the service. So I just wanted to highlight that to you. So I don't know whether anybody has any further comments on the composite report or questions. Councillor Davis.
Yeah, I'd just like to go back to the public health update in the report. Go back to the beginning of this meeting. Nobody in this room is disputing that Devon needs representation with the ICB clustering. That was a really uncomfortable meeting. Mr. Govic came along and he gave his report, and I found it very uncomfortable actually how he was treated in here. There's clearly history that's gone on that we don't know about. So I note that there's a Health and Wellbeing Board meeting later this week, and I'm really hoping that the leader of the council and the chief executive can do some further work on that to resolve the issue, and probably not do it in such a public domain.
Thank you.
I think the importance of scrutiny and offer work, anything we do, is being able to do difficult things, and we have a new value in the council, which is transparency. And I think if we're in dispute about governance, then I do think as an organisation we do need to be able to have that conversation. There's many conversations that have taken place in the background to try and resolve that governance issue, and I want you to assure of that hours and hours. But sometimes if there is an issue with governance, then we have to make sure that we are transparent about that. And it does become bumpy and it is difficult, so we recognise that, but sometimes that is required to resolve such strategic issues such as governance. I think the other piece here is in response just to how we develop our performance information, then, you know, scrutiny should be a really robust place because we're holding each other to account, and you as members are holding us to account. And I think when I look at some of this performance information, I'm so happy to take forward any feedback in any way. I still think there's a direction of travel here. We've just heard that there are projections from one of the officers in terms of a key issue such as safeguarding. We had a debate on dolls earlier today. So having looked at the children's journey, because it's under external scrutiny, then we have developed and evolved our performance framework to a very different approach, because it's been under scrutiny, you know, month by month. So I would say there's still a bit of work that we need to do based on the feedback we've had today, and to develop that for you. So I just ask you to consider, you know, how we might do that. This is certainly a level of performance and scrutiny that is evolving, and it is new to us as an organisation. And I think we do have a long way to go with this. And that's called out in our recent peer assessment, where we talk about how we lift those standards and much more ambitious. So quite happy to take additional feedback into this through the chair and the vice chair, and we can debrief and add in a different level to this coming back. But I would say that, you know, if scrutiny is not bumpy at times, and I don't think we're doing our job properly. And I'm happy to reflect on, you know, why it was uncomfortable, but, you know, I do think sometimes that's required to get the best outcomes for our residents.
Thank you, Councillor Dawson.
Thank you. I just wanted to support the Chief Exec with that, really. Sometimes we do have to have really difficult conversations, and we're talking about representation of the whole of Devon, really. And I felt that was necessary this morning, and sometimes that does feel uncomfortable. I think it remains professional, but it was still that uncomfortable conversation had to be had, and we had demands that for better service for Devon. And it was the same when we were dealing with South West Ambulance Service. Nobody wants to throw stones at heroes, but actually there were decisions being made that weren't safe for Devon as we felt it, and that was our job to push back on that.
I don't have a problem with difficult decisions, and I don't have a problem with difficult situations. I have a problem with the Chief Executive and the Leader of the Council failing to resolve this issue in their September meetings of last year.
Well, I'm happy to say that there have been a number of meetings. What you heard this morning from the advisor, this is a difference of opinion. So it's not that if you have two organisations that are interpreting the guidance differently, and what we heard is that there are no rules on this. What we also heard this morning is that another area of England resolved this last week, and the way that we were seeking, but that has not been the resolution here. I cannot force another organisation to hear our view or to take that up. And as I say, the leader of the council has been involved in 2 meetings with me with an aim to try to resolve the matter. And it came here because it was not resolved, and that's good scrutiny. We will continue to try to resolve the matter to represent the residents of Devon. And in this situation, we either accept what another organisation is saying, or we hold true to where we see best practice in the country at the moment. And last week, another part of England followed through on a model that we're seeking, and we don't have that here. And when it takes to representing, as we heard today, the scale of Devon, the scale of savings, the scale of change, I just don't understand why it's so difficult for us to be part of that.
Thank you. And I would I support fully what the Chief Exec Donna Manson says, and certainly from my point of view, I would try and look at it objectively, and I'm you know, looking at it objectively. There's no reason why we can't have that representation, and I don't think it's a question of, you know, our leader and chief executive having failed to resolve matters outside the committee. I think it's that there's a governance issue that there's no reason why we can't be represented as a council on that, on the ICB. So I think it's perfectly right and proper that we consider that as a committee in the public space, in the public domain, live streamed, so everybody can see what we're doing for our residents. And you know, residents are invited and can attend if they want, and if they disagree with what we're doing, then they're able to articulate that. But I think it is about being transparent, and I think it's about being firm but fair. And I think we are fair as a committee. I don't believe that we have overstepped the mark or been unreasonable. Yes, it can be uncomfortable, but I think we're here and we have a job to do, and we have to do it to the best of our ability. And I believe that as a committee that we do that. So I think we should probably see if there's any other items on the general update that anybody would like to comment on. No. Okay, thank you. So Scrutiny work programme, we've got a meeting coming up, haven't we, Dan, which we haven't got the date yet, but the date will be 16th of April. Do we have a time? 10 o'clock. So that will be on Teams, so we can discuss items for our.
Okay, that's on the transformation.
Oh, that's on the transformation. What
We haven't
about?
got a date for the work programme yet.
So we've got a standing overview group to look at living well in Devon. Standing overview to look at. We're trying to arrange the date, aren't we, to go to Somerset? We've been pressing for that. We're getting that very soon, and then we'll be meeting and you'll circulate the details of that. And then we're also going to be holding a meeting to discuss work programming going forward, and we'll look at including the items that we've looked at today, which is end of life care and homelessness, and all the other items that are currently on the work programme as well to prioritise. So massive information. Champion against domestic and sexual violence and abuse. Councillor Dawson.
Thank you, Chair. You might have seen, but if you haven't, please do see the new 4-year plan for the Safe Lives, Strong Communities 26 to 29 strategic plan for Devon. And that's been a lot of work with public services, voluntary sector, community partners, basically a multi-agency plan to kind of map what the response to deal with crisis and also prevention and all the rest of it across Devon. And it also specifically maps out what the remit will be for each of the champions against domestic violence and sexual abuse as well. So if you haven't seen it, please find it and look at it. It's very exciting. Thank you.
Thank you. And I don't believe there's anything else on the agenda. So thank you very much for attending, participating. Thank you very much. Meeting closed.